Hi, good morning. PAHO and the WHO welcome you to the regional commemoration for the World Diabetes Day 2023. This we are focused in seamless accessible for primary health care in vulnerable communities. Today, more than 1 century after the discovery of insulin, we are facing a hard reality. Around 18 million diabetics do not have access to the drugs. This also represents a call for everyone. The member states of the WHO Probando, 1, 2, 3. Probando. The PAHO and the WHO welcome you to the regional commemoration of World Diabetes Day. This day, we are focused on guaranteeing egalitarian access for primary health for diabetics. Today, more than a century after the discovery of insulin, we still face a hard and challenging reality. Approximately half of diabetics do not have access to the treatment they need. This situation, this challenge, does not only reflects the challenges of our reality, but it's also a call for us. The member states of the WHO are committed to strengthen responses for diabetes, both for their national programs of non-communicable diseases, and this includes improving surveillance for diabetes to develop strategies for prevention and control of diabetes, and guaranteeing uninterrupted treatment for those who need that. On this very important day, we highlight our commitment in working together to overcome these challenges. It is mandatory to improve the life of those living with diabetes and improve the reality in the communities. In this regional commemoration of World Diabetes Day 2023, we are welcomed by Dr. Ruiz Welcome Miranda, Undersecretary of Prevention and Treatment of the Ministry of Health in Mexico. We're also accompanied by Dr. Slim Slama, Head Unit Chief of Non-Communicable Diseases of the WHO at Geneva. Ms. Silvana Liciana, Unit Chief of Non-Communicable Diseases of PAHO. At this moment, we're going to listen for a message of Dr. Jarbas Mamusa, Director of PAHO. Please play the video. I am honored to address the public health community, to address the World Diabetes Day. Primary health for diabetes is very important for the PAHO, as we are currently working with the region of the Americas to strengthen and make progress to universal access and coverage and creating resilient national systems based on primary health care. We are all conscious that diabetes is a public health care problem in all the world. Diabetes has quadruplied in all the world, and we have 500 million in 2030. The region of the Americas is the most affected by diabetes worldwide. In just 30 years, the number of people with diabetes increased from 18 million in 1980 to 62 million in 2014. And more than $340 million people died worldwide by diabetes and its consequences. It's been more than a century since the discovery of insulin, and nevertheless, a lot of people have difficulties accessing insulin, and basically diabetes like reactive strips and glucometers. Also, a lot of people suffering diabetes are undiagnosed due to a lack of primary healthcare services. That's why in this very important day, the PAHO strengthened their efforts to highlight diabetes as a public health issue and improve the access to health services, the procurement of drugs, and treatment for diabetes. This is essential to control diabetes, prevent their complications, and increase the life expectancy of people suffering from this condition. Each country needs to guarantee that healthcare services is available for patients and is included as part of the primary healthcare services. In some cases, this could mean to offer healthcare services outside traditional environment and working with community professionals to work together for this goal. Drugs and all the services related to diabetes need to be affordable and accessible for those who need this. Therefore, we ask the governments to come up with better strategies to supply both the drugs and services related to diabetes with better prices, regardless of how they procure them. It is also essential that the health professionals guarantee that people suffering from diabetes fully understand the risks and have access to the information and everything pertinent to control this condition. This includes being active, having a healthy nutrition, and to strengthen this, we have implemented a very corporate strategy to have a better strategy, whose goal is going to better the procurement and access of services related to diabetes, especially focused to vulnerable communities, so that nobody is left behind. Through this regional initiative, we strive to increase the diagnosed patients for diabetes, improve the coverage of the treatment, and improve the control rates. Therefore, we are working together to create awareness and fight against this affection in the World Diabetes Day, as well as strengthening our efforts to provide a universal access and better treatment for diabetes in all the region. And this is part of our efforts to provide a better treatment for non-communicable diseases for all in the region of the Americas. We thank Dr. Jarbas Ragosa for these welcoming words and this invitation. And in this moment, we're going to listen a message from Dr. Mikkelsen, Director of Non-Communicable Diseases from the WHO.
Welcome to all who have gathered here today in Mexico City to commemorate the World Diabetes Day. First, I would like to thank Paul for organizing and the Secretariat of Health in Mexico for hosting this important event. I would also like to welcome representatives from ministries of health across the region of Americas, authorities from the Secretariat of Health in Mexico, and community and civil society representatives who are here in attendance today. World Diabetes Day is an important opportunity to celebrate the successes we have made in advancing the diabetes agenda as a global community. But it is also a reminder of the urgency behind strengthening prioritization of diabetes across national, regional, and global health agendas. The prevalence of diabetes in the POW region is projected to increase with 50% from 2019 to 2045. In addition to these disheartening statistics, globally, diabetes is the only of the four major non-communicable diseases where premature mortality is rising. In response, WHO launched the Global Diabetes Compact in 2021 with a vision to reduce the risk of diabetes and to ensure that all people who are diagnosed with diabetes have access to equitable, comprehensive, affordable, and quality treatment and care. Member states across all WHO regions adopted 5 historic global diabetes coverage targets in May 2022, and this has strengthened the momentum for diabetes prevention and control. In order to accelerate progress towards these targets, POW has been the front runner in driving regional implementation of the Global Diabetes Compact. Thank you and congratulations. I'm thrilled to see how POW's leadership have resulted in increased advocacy, expanded implementation of diabetes guidelines and technical packages such as HEART-D, and mobilization of essential stakeholders across the region. We must use this momentum to advance our collective goal, a world where people living with diabetes have access to the care they need and the risk of diabetes are minimized. Thank you, and I wish you a successful day ahead of fruitful discussions, learnings, and directions for the future. Thank you.
Agradecemos el mensaje de la doctora Bente
We
Mikkelsen
welcome the message from
invitamos
Dr. Mikkelsen,
a la
and we
licenciada Silvana
invite
Luciani a que nos dirija un
Ms.
mensaje.
Silvana Luciani so that she can give us an opening word.
Gracias, muchas gracias y muy buenos días a todos y a
Thank you
todas.
so
un
much,
gran
and good
honor
morning,
estar aquí con
everyone.
todos
It's a great
ustedes
honor
para
to be here
celebrar
with
este
you,
Día Mundial de la
celebrating
Diabetes.
the Diabetes World Day.
Quiero darles la bienvenida a este evento, a todos los
I would like to
participantes que
welcome
están
you, all
aquí
the
asistiendo en la
attendees to
sala en
this
México, en la Ciudad de
session,
México,
for
pero
the
también
people
a los
that are at
participantes
Mexico
conectados
City, but
por Zoom en
also to the
nuestro
people
webinar. Así
that
que
are
muchas gracias por
connected via
acompañarnos en este
Zoom
webinar.
in
Quiero
our
empezar
webinar. So thank you so
expresando
much
desde
for
la
joining
OPC
us in this
nuestras
webinar.
condolencias para
On
las
behalf
familias y todas las
of the
personas
PAH,
afectadas
I
por
would
el
like to express
desastre de este
my
año en
condolences
Acapulco
for all
y
the
estamos
people
expresando
affected
nuestra
by
solidaridad con la
the recent
población mexicana
events
en
in
este momento
Acapulco.
duro.
And
Bueno,
we are with
lo
you
que
in these
nos
hard times.
los que nos conviene hoy día es la
Well,
conmemoración del Día Mundial de
we
la
are here
Diabetes y
today
quiero
because
empezar
of the
agradeciendo a la
Diabetes World
Secretaria de
Day.
Salud, sobre todo al doctor Ruiz
And I
López
would
y
like
todo su
to
equipo y
thank
a
the
la
Ministry of
OMS,
Health in
a
Mexico,
SLEM y
Dr.
todo su
Ruiz,
equipo para
and all the team
acompañarnos
in
en este
Mexico,
evento y todos
and
los
the rest
compañeros
of
de
the
otros países de
organizers
América Latina y el
and the
Caribe
teams from
que han
other
viajado de gran distancias para
organizations, both
acompañarnos
in the
y
Caribbean,
compartir
Latin
sus
America, that have
experiencias.
traveled here to join us and share
Y
with
es una
us
buena oportunidad de revisar nuestra preocupación
This is a
común que
great
tenemos con el
opportunity to
aumento de
review
la
our great
prevalencia
concern
de diabetes y
with
cómo
the
podemos
increase of the
prevenir y
prevalence
detener
of
este
diabetes
aumento
and
en
how we
diabetes.
can
Pero también
stop and
aprovechando el tema de
prevent
este
this
año
increase.
del Día
But
Mundial de
also,
Diabetes que está enfocando en la
speaking of
atención primaria de
the
la salud,
World
queremos mejorar
Diabetes
también la calidad de atención y ver cuáles
which is a very important issue for the PAHO, we're going to review which are the most effective strategies to arrive to a better diagnosis so that we can provide a better treatment to fight their affection. Currently, there are 72 million people suffering from diabetes, but we know as population is increasing, this number is also rising, which means that we need to act quicker than we're acting right now. There's a greater urgency. We need to change both the public policies, but also strengthen interventions, especially in primary health care.
Así que en esta reunión será una buena oportunidad para
So
discutir
this
cuáles son
meeting
los
is going to be
desafíos
a
para
great
mejorar la
opportunity to
prevención y
discuss
control
which
de la
are the
diabetes, para
challenges that
conocer
we
un poco cuáles
face
son
in
las
preventing
estrategias que se
and
está
attacking
implementando
and
aquí en
treating
México
diabetes,
y
which are
también en
the
otros
strategies
países
that
en la
are being
región para
implemented in
aprender uno
Mexico
del otro
and other
y
countries in
cómo
the region
podemos
so that we can
innovar,
learn
cómo
from
podemos
each other
incentivar
to
todos
see
los
how we
cambios
can
que se requiere para
innovate,
disminuir la
foster
prevalencia de la
all the
diabetes y
changes
para mejorar
to
el cuidado
decrease the
de las
prevalence
personas
of
con diabetes.
diabetes and
No sé si
improve the
ustedes
treatment
han
for
dado
people
cuenta,
suffering
pero
from
ya estamos
diabetes.
12 años después del primer reunión de
We-
alto nivel en las Naciones Unidas para llamar atención
These
a
are
esta
12
problemática de las
years
enfermedades
after
no
the
transmisibles,
first
incluyendo
meeting
la
in the
diabetes.
United
Y en este
Nations
primer
for
cumbre mundial se
non-communicable
acordó
diseases,
un
including diabetes.
compromiso
And in this
para
first meeting,
reforzar todas las
we
estrategias
came up
multisectoriales
with
con todos los sectores del gobierno y la
commitment
sociedad civil.
all
Pero
the
después de
sectors
12
from
años y
government
tantos
and other
compromisos,
parts of civil
resoluciones y se ha
society,
acordado
and
metas
after
globales, incluyendo
a lot of commitments,
detener el
resolutions, we
aumento de
came
la
up
diabetes
with
y la
different
obesidad. No
global
estamos en un
solutions
buen
to
camino para llegar a esta
hinder
meta global.
diabetes
Así que
and
esto nos llama
obesity,
la atención que
but
tenemos que
unfortunately we are
cambiar lo que estamos
not
haciendo
on a
ahora
good
para
path.
cambiar los
So we
paradigmas
need
en la
change what
entrega de
we're
los servicios, cambiar las
now
políticas
to change the
públicas y
paradigms, the
reforzar lo que estamos
services,
haciendo, pero
public
con un
policies, and
enfoque en
strengthen
la
what we're doing,
multisectorialidad.
but
Así que con
with
esto voy
a
a
more
cerrar las palabras de
comprehensive
bienvenido y
focus or
espero
approach.
que disfrute
So
de este
these are the
webinar.
welcome
Gracias.
remarks, and I hope you enjoy the training. Thank you so much.
Agradecemos las palabras de la licenciada Silvana Luciani.
Miss Silviana
enseguida,
Luciani.
Solicitamos amablemente al doctor
And
Rui López
now
Ridaura
please
nos dirija
welcome
unas palabras.
Dr. Ruiz, welcome Miranda. Mr. Ridaura.
Buenos días, todas y todos. Muchas gracias por estar aquí. Muchísimas gracias a la Organización Mundial de la Salud por haber escogido México para hacer esta celebración. Hace como 3 o 4 meses nos avisaron y estuvimos viéndolo, platicamos en su momento también con las autoridades y vimos que era un excelente momento también, no solamente para tener y ser huéspedes de esta celebración por parte de OMS o EPS, sino también en el momento que nos encontramos ahorita de una transición y una transformación acelerada de la atención médica, donde la atención de diabetes, de los más de 17 millones de personas con diabetes que hay en México, de los cuales tal vez 10 millones están diagnosticados, pues representan la mayor carga, no solamente de mortalidad, no solamente de discapacidad, sino también de una carga para el sistema de salud, ¿no? Ahora justo que vengo llegando, hemos estado atendiendo el problema en Acapulco y por eso también el doctor Alcocer se disculpa por no poder estar acá. Aún en situaciones de una gran tragedia, lo que está cargando el sistema, por ejemplo, en Acapulco, en las unidades móviles, es las personas con diabetes manteniendo y continuando el tratamiento, ¿no? Entonces, realmente la atención de diabetes y en general del riesgo cardiovascular, pues representan el principal problema de salud pública, no solamente en México, en prácticamente todas las entidades federativas, también en poblaciones rurales, urbanas, en los diferentes niveles socioeconómicos, cosa muy similar que también se traduce a nivel global. Por eso, el día de hoy, 14 de noviembre, que se celebra, digo, como ustedes saben, el 14 de noviembre de 1991.
In 1991, Dr. Brady was born. I think that he was not the unique one, but he was the one who isolated the insulin in the 21. As Dr. Vidauro said, we have discovered an isolated insulin with Dr. Vacuum, but it's a problem that it's not only knowing the physiological problems. This is something more complex than the physiology that at that time Dr. Banking discovered, isolated, and provided a huge step to understand the diseases. But 100 years after, we realize that it is not only finding a hormone or finding a treatment, but the diabetes problem is much more complex. That is why in 1991, thinking in the 100 years since Dr. Banking was born, the WHO recognized the problem of public health represented by diabetes, and that's why they designated this day, as many other days do, for the awareness and visibilizations of issues, so that we can hold this kind of events. This is not the only event that when we remember the diabetes, because almost in all the events when we talk about public health problems, but today together with the WHO, and I wanted to thank all the team coming here besides the Dr. Slim, Dr. Silvana. We have a team who has been with us in the last week, seeing what we are doing and also helping in this transformation that we have been talking about during the seminar. So today we are calling people, and not only the health institutions. I thank them very much because we have the representation from the IMSSS, the representation of ISTE, Benestar, Mexico City, societies, the academics, because I can see here from the Nutrition Society. This is a good time to call everybody to join their efforts, not only the health service sector where we are working to unify in this transformation, but also to the multiple stakeholders. We must remember that diabetes and the main risk factor, which is obesity, that are consequences of an environment where we are moving as the consumers. And if we do not modify the environment, if we do not take advantage of this day to call for the urgent need to modify the environment where we are moving in, this will involve a strong action from the state to regulate those environments, because otherwise we are not going to be able to control this epidemic. The priority is also taking care of diabetes. We are going to talk about that also, what we cannot put aside, especially in a day as today, the need to regulate the environment, which has a huge influence on food sector. So thank you very much to you all. Thank you very much to the WHO. And I am inviting you to stay here to attend the seminar that we are going to be holding to discuss the details. Thank you very much. We thank Dr. Rui Lopez words. And with these words, we are concluding our inauguration. We thank for the attendance of all the members in the Presidium and everybody here attending in this room and those attending virtually. And we are inviting you to take your seats. Now, to start our program, we are inviting Victor Tamil Salinas, who will be sharing his experience living with diabetes. Good morning, everybody. Men and women, and everybody attending and being here with us in this significant date. We're going to be talking about a chronic disease with a higher prevalence in our country. Be you all welcome. My name is Victor Maria Tavares Salinas. I am 67 years old. I work in the health services public sector in Mexico City. I am allocated to the Alvaro Obregón section. My history with diabetes started because of one of my aunts on my mother's side. During my life, I never took care about the challenge for the people who has or had family with a diabetic profile. In my case, myself with my Amparo aunt. So before taking all the measures, we believed on how unfair the disease was, because it was a very bad action on my aunt, mostly because she was so generous with her family. We as a family, we didn't have the necessary vision to see the burden that our family was carrying and the fatal outcome. That was an alert that we must have interpreted to take care of the consequences and not be only grieving because she left. Some years after, another of my cousins had the same disease. He was older than 50 years old. This was during the pandemic. And as many men, he was the party soul, but he didn't took care about the medication. And this had a result on his life. In my concrete case, in the 2010, I went for some examination because I suspected I was diabetic. The results showed that my blood sugar levels were very high. Then I moved to an internist doctor, but that was a mistake because I just started the medication with metformin, 500 mg. I thought that my problem was already resolved and that I could continue with my family and labor activities as usually done during the last 54 years. The truth is that I continue with the same habits as always and the same non-moving life, not having a good food, tortas, tacos, moving in public transportation for so many hours. I did everything, but I didn't take care of myself. But that was not all. The worst thing is that I still thought in the power of one pill, saying that it was going to be a miracle, that by just taking it every day, then the rest of my concerns were in the second and third level. So I assumed that I could continue with the same exercise as always without having any result, breath, either sweet or salty. I laugh really very loud with a neighborhood because he escaped from home and going to buy some bread. He was trying to eat the bread, hide it, but he was getting some issues with his wife and offsprings. But then, for my own shame, I was doing the same thing. I justified my actions, saying that the people said otherwise. that the Mexican donuts are not bad, that bolillos are not harmful, that carnitas once a week do not have any effect. And every pretext to continue self-misleading me. For example, I avoid eating cakes and sugar breads, but only when I was in public. I can remember somebody that before going to his doctor appointment took green tea, and another one that he could eat everything he could because he had the permission of the doctor. In my case, I have no problem with soda drinks that I stopped drinking 30 years ago. Even though I have some numbers as 304 and above, then can you imagine if I continued getting both soda and bad food? In the 2022, I was positive to COVID, and then that besides my comorbidity, that took me to look for professional help. Then I went to the UNEM for chronic diseases in San
with Dr. Manuel Molina, and then I was asked to have studies because I wasn't controlling my disease, and they actually instructed me that I should make more physical activity to overcome this critical stage. The process needed to be comprehensive, and I needed to implement critical needs and processes to change these dynamics. Fortunately, I was helped by the personnel and the staff from the chronic disease department. This hasn't been easy.
I am not the best patient either, but I am still striving. As many other colleagues going to the same place, I am still fighting, not against the wind meals like Don Quixote, but against my own habits that I have so much adhered to. I know that I am not by myself, and neither the millions of people who have these statistics of being diabetic. I mean, 17 out of 100 people, according to OCDE, as vulnerable population. We have this network of UNEMs and chronic diseases, more than 230 units, as well as being prepared for using vaccines, COVID, so that we are better protected. These opportunity factors are so powerful before the challenge faced by most of the people. Some people may say that there's still a long way to go, but the truth is that everybody here, they already have this burden, and they have to go forward. They have to face the challenge, and they should get more victories in this fight against diabetes. Thank you very much. We thank the words of Dr. Victor Tamiz, and thank you for being so open for his contribution to this commemoration, reminding us how much we must know the experiences of the people living with this disease. Now, Dr. Bianca Hemmingsen, officer on non-communicable diseases in Geneva, WHO, who will be giving us a presentation. Muchas gracias, Mariana.
one back, I do it here. So thanks a lot. Yeah, my name is Bianca Hemmingsen. I'm the medical officer working in the World Health Organization under the leadership of Slim Slammer, who also is in this event today. Thanks a lot for inviting us for this event. It's really an honor to be here and celebrate World Diabetes Day with you in Mexico. As mentioned by Silvana and in the introduction, there's increasing burden of diabetes in Mexico, but it's not only Mexico who faces the problems with the rising burden of diabetes, it's a burden across the globe. So in 2021, member states, they endorsed the diabetes resolution with the title, Reducing the Burden of Non-Communicable Diseases Through Strengthening Prevention and Control of Diabetes. This resolution lists a lot of asks to the member states, but it also gives asks to the World Health Organization. I will not go through all the asks, but there are 8 in total. One central component is development of global diabetes coverage targets and pathways to achieve the targets. Here is listed some of the other asks for the World Health Organization, like regulatory requirements for diabetes medicine, and make a progress report as well. It was quite timely with the resolution because 1 month before we had the Global Diabetes Compact launch, which was done together with the government of Canada. And it was at the same day as the anniversary of the discovery of insulin. And again, we had a very big support from the PAHO region. Of all the speakers, we actually had 15 speakers from PAHO. There in the Ministry of Health from Canada. We had Silvana that also is here with us today. And the picture there is from the Mexican Diabetes Federation, where we had Dr. Fernando speaking as well at the Global Diabetes Compact launch. The vision of the Global Diabetes Compact is to reduce the risk of diabetes and to ensure that all people who are diagnosed with diabetes have access to care and quality management. The Global Diabetes Compact should achieve its objective through 6 work streams. I've listed them here, but they should not be seen as silos as they all interact with each other. The first work stream is access to essential diabetes medicine and associated health technologies. The second work stream is technical products. The third is prevention, health promotion, and health literacy. The fourth is country support. The fifth is research and innovation. And the sixth work stream is governance. I will now go through some of the main activities we have for each of these work streams. Work stream 1, which is access to essential diabetes medicine and associated health technologies. We have engagement with the pharmaceutical companies and companies of associated health technologies. And we have developed 31 asks for them in order to help them to increase the access for diabetes medicine and technologies. I will not go through all the asks and the status of it, but just share some of the achievement that we have so far. We have pre-qualification of human insulins in September last year. And this year we have pre-qualification of insulin. And this should help ensuring quality assured insulin on the markets and hopefully also reduce the prices. There have recently been an announcement of transfer of rights and technology for local production of insulin in both Egypt and South Africa. And currently we are working on pre-qualification of blood glucose meters and HbA1c point of care test. Other things to mention is that we have recently updated the essential diagnostic list, so it now also includes personal use of glucose monitoring devices. And we are developing an NCD medicine forecasting and quantification tool, which also will include diabetes medicines. The second work stream, which is technical products. The main technical product that we recently have developed is a global diabetes coverage targets, which are listed here. They were endorsed in 2022 by the World Health Assembly, and the targets are that 80% of people with diabetes are diagnosed, 80% of people with diagnosed diabetes have good control of glycemia, 80% of people with diagnosed diabetes have good control of blood pressure, 60% of people with diabetes of 40 years or older receive statins, and finally that 100% of people with type 1 diabetes have access to affordable insulin treatment and blood glucose self-monitoring. And these targets should be achieved by 2030. In order to support countries to achieve the targets, we have several technical products in the pipeline. One of them is pharmacological management of type 2 diabetes. There have been a lot of addition recently on essential medicine list, and a lot of new treatment options are there. And people ask, do they have a role in the treatment and where to put them? So it's the treatment of pharmacological treatment we will look into. We have commissioned a Cochrane review on insulin thermostability, which was published last week. And the data there contained previously unpublished data from the pharmaceutical companies. And we will develop a brief from the World Health Organization based on these data. Then we are working on insulin therapy in adults with type 1 diabetes, as well as in both adults, and also a guideline on management of diabetes in children. And finally, we are about to finalize a pricing survey on insulin and health technologies to see the pricing. In order to monitor the target, we are working on the monitoring framework for diabetes, and we also will update our prevalence data. Other activities is the operational handbook for tuberculosis and diabetes, and I understand you here in Mexico also have plans for integration of tuberculosis and diabetes. We had a meeting last month where we discussed the operational handbook, and we also have a presentation from PAHO there in Brazil, was represented at that meeting. We are developing guidelines for hyperglycemia in pregnancy, which a request we often get a question about from countries, how to who to test, how to manage. And finally, we are looking at a framework for integrated chronic kidney disease in primary healthcare setting. The third work stream is prevention, health promotion, and health literacy. And there we have the acceleration plan to stop obesity. And there are actually 9 front-runner countries in the region of the Americas, and they're in Mexico, actually. So you're already doing a big effort, I know. We have recently, another risk factor for diabetes is tobacco use, and we have recently published a brief on tobacco and diabetes. And this will be available in Spanish as well. And there we have ongoing collaboration with other units across headquarters. Careful of time, I will not go in details with all the country support that we do, but of course, country support is one of the most important thing in this Global Diabetes Compact workstream, as it all has to show some effect on the ground of what we are doing. Firstly, we have the regional adaptation of the Global Diabetes Compact, and again here, PAHO with the front runner, the first one to actually do the regionalization under the leadership of Silvana. We have a lot of requests for adaptation of the HARTS-D and other diabetes guidelines into country context. And then we provide strategic and regional strategic support for both national and a regional diabetes meeting. And then we have also supported regions and countries with grant proposals on request. I can see my time is soon up, so I will go a bit quick through the last slides, but this is pictures from the mission we had in Ghana and Uganda, where we had attendances from the ministers of health, and the objective was to accelerate progress to the global diabetes coverage targets. Other regions that also focus a lot on diabetes and hypertension is the Sierra region, and they recently launched an initiative as well, and India has committed to have 75 million people with hypertension and diabetes on standard care by 2025. Other countries in Sierra has also given this ambitious commitments. And here's an example of a country proposal support. When the Global Fund, they said they integrated NCDs into the HIV and tuberculosis grant proposals. We went to a workshop arranged by Afro colleagues to support the grant proposal development. For research and innovation, which is the 5th work stream, we are working on a prioritized research agenda, and we hope to launch this next year. We have received inputs from experts across all regions, including PAHO, of course. Yeah, I think I'll go to the next slide. This shows the governance structure of the Global Diabetes Compact. And as you probably can see from this slide, we need all hands on deck, and we have a very broad engagement structure. So please catch us if you want to be engaged in some way or another. I'm sure there's a seat in one of all the structures we have. Of course, we have engagement with regions and member states. We also have a technical advisory group on diabetes, and we recently shared the call, and we are currently in a dialogue with the different regions to make the final selection. We have the Global Diabetes Compact Forum, which convenes twice a year, and we actually have interpretation in Spanish for these events. And all are welcome to join. It's NGOs, academia, and other research institutions that has an interest in diabetes. The objective is information sharing. Then we have people living with diabetes consultation once a year, and then we are engaging with the private sector. My last slide will be on ways on how you can engage. I have also in the front, there's a tiny card on the Global Diabetes Compact with a QR code, which will lead you to this information as well. But just to let you know, we have a Global Diabetes Compact newsletter, which is published once a month. There we advertise the events, job openings, and other activities. Then we have the Global Diabetes Compact Forum, as mentioned. And then we, you should be very welcome to apply for the forum. We have actually no stakeholders from Mexico as it is right now, but several from other countries in the region. That was all, and sorry if it was a bit of a time.
We welcome Dr. Bianca Helmison, who introduces us to the Global Diabetes Compact. Now, please welcome Dr. Slim Slavan, Chief Unit of Non-Communicable Unit of PAHO, who's going to introduce technical resources for the WHO for prevention and treatment, comprehensive prevention and treatment for diabetes.
Hola, good morning, good afternoon, colleagues. And let me first join my director, Dr. Bente Mikkelsen. My name is Slim Slama. I'm the unit head for NCD management. So it's a unit that is responsible of the management of the most common non-communicable disease. So we cover a large portfolio from cancer, cardiovascular disease, diabetes being one among them. I would like to first, once again, reiterate our warmly thank and we are really pleased and honored to be here. And in particular, thank also the government, Dr. Rui Lopez Ridoro and his team here at the Secretary of State of Health, but also our country team colleagues, our colleagues from PAHO as well, distinguished representative also from different ministry of the region. I think it's really, for me, important when whatever we do at WHO is to serve you and serve the people that we are meant to serve. And I was very pleased that Senior Victor was among us, because at the end of the day, this is what means for us. The work in WHO is to serve the people and also to design with you as much as we can the health system that is able to respond to your needs. So thank you very much for that. I will try in the time that is given to unpack one of the streams that my colleague Bianca just highlighted, is the technical products. WHO is known for setting norms and standards to develop guidelines. And of course, with the resolution on diabetes that you have seen have been adopted by our member state, by the Global Diabetes Compact, we try also to adapt the technical assistance to the development of norm technical products to support further the operationalization of those recommendations, but also the achievement of the targets. Does it work? While we are waiting, I wanted also to thank, I think we have almost 400 people joining us online. So just to acknowledge also the people that have taken the time and joining us virtually. So as, let me try if it works. Yes. I will skip the resolution. I think we have already alluded to that. And as I mentioned, I will specifically focus on the work stream 2 that is related to the technical products of the compact. Yes. And implementation is key to achieve the targets, and the targets are not aspirational. We heard a lot sometimes in the preparation of those work, and we worked with a global expert in developing those targets for consideration for member states. We try to look at what are the core elements of optimal care for diabetes, but also looking at what is achievable, what is measurable, how is it measured at the moment, and this is how those targets has been developed. So they are focusing mainly on what we call the treatment cascade, the ability to detect people, but also to put them under treatment with achieving coverage and control in particular. On aspect on glycemic control, the hypertension in particular also is an important and even sometimes more important cardiovascular determinant, as well as making sure that we can prevent cardiovascular event among this population. And of course, for those who live with type 1 diabetes, access to insulin is life-saving, it's mandatory, and this is something that the target can seem very high. It's a target that also, it's a human right. It's not something that we can have it as an afterthought. So many resources have been developed over the year, and we are still, developing it to support some of this work through the compact and the resolution. More recently, I was given the responsibility to coordinate with the colleagues across WHO what we call the NCD busbuy, really the list of cost-effective intervention for the prevention and management of non-communicable disease that include, of course, interventions that are relevant for diabetes. We have, since 2008, 9, 10, developed a package of essential intervention for NCD called the WHO PEN that many of the countries have used as a model for integration. And as part of the PEN, we have tried really to open up more the focus on hypertension and diabetes as an entry point for the integration at the primary care level. So the technical package of hearts and pen are not something that are opposing each other. It's just that the pen cover a larger range of diseases and conditions like chronic respiratory disease, while the hearts is really trying to unpack what is needed for hypertension and diabetes to be integrated at the primary care level. And we have tried to adapt our packages to include better also diabetes with the HeartD packages. For all those guidelines and packages, we need essential drugs. And every single year, there are new applications, and we need always to strike a balance. The applications are open to anyone, any organization can apply and make a case for introducing new drugs and technologies as well on whether the in vitro drug list, the diagnostic list, or the medicine list. So it's open to anyone. But of course, from a WHO perspective, we will review those applications, we contribute to it. But there was an expert committee that is an independent committee that really advise every 2 years on the introduction of new medicine and technology. Now, this is extremely important because many countries think that what sits on the model list needs to be at the national level. But there is a need always to adaptation, to contextualize based on your burden, but also your capacity, your resources, what goes into the list of drugs and medicine. Technical products are important also to support the uptake of the medicine, from quantification to being able to forecasting the needs. So we are also developing, as we go, tools to be able to assess availability, affordability of essential drugs, but also being able to forecast them as you are planning your program. As Bianca just mentioned, and I think with the new cycle of funding of the Global Fund, we are extremely interested to look at the element of comorbidities, in particular between HIV, tuberculosis, malaria, but also in particular diabetes and tuberculosis as an entry point. And we have developed some guidance on this. And unfortunately, with the reference was made to the Otis hurricane in Acapulco, but I come from a region where half of the country are in conflicts, and we have developed a lot of support also for country in emergencies, including the development of an NCD kit. And I think in situations like in Latin America and in the region in particular, with a lot of natural disasters that are occurring more and more frequently, there is a need to think about emergency preparedness and response, including for diabetes, pre-positioning of some of those drugs in order to be able to maintain continuity of care. This is an area of work that we are developing as well. And diabetes has a component, even requested as part of the resolution. So these are the full list, and I'm just going through some of them. These are the interventions that are the cost-effective intervention. It doesn't mean that an intervention that is not on a list is not an important intervention. These are interventions where we have analysis of cost effectiveness, and we can see the impact and also the threshold that are really the core intervention that should be included. But of course, in the portfolio of diabetes management, you might consider others. And we have received the mandate after the last World Health Assembly to be able to continuously update this list as the evidence grows, where we'll try to integrate new intervention, but also link to those intervention economic analysis. As I mentioned, the pen was the entry point to the integration at the primary care level, and we have further developed it with protocols that were very simple because we are catering to the needs of the world and also to low and middle-income countries. So some countries have seen this as probably too simple or not necessarily sophisticated to their settings, but these are essential intervention that is a very good entry point for the management and early detection of diabetes. I will skip some of those innovation with the HAS technical packages, and also to bring some simple protocols about diagnostic protocols, but also management that need to be tailored to your own context, taking into consideration, as I mentioned, the essential drug list that you have in your countries. And we know even here in Mexico, we're discussing it. It's a very challenging with a lot of influences about what got in the list of national list, but also what is outlined in your own guidelines and how you can adapt it as evidence grows. And we have a lot of pressure, in particular with the emergence of analogs, both for insulin, but also for oral drugs. We are trying to find the right balance between recommending this, but also trying to address the high cost of those drugs on the market. So trying to introduce them on the EML might drive some aspect of competition, but it will not come alone. So we need also to make sure that we're protecting some of the drugs that are still very effective, specifically in low-income countries. And this is my plea also, because often I hear when I visit countries, like human insulin is not an old drug for low-income settings for the poor. These are essential drugs, and it will remain essential drugs. And we have seen in the market analysis that many of the suppliers are removing their production of human insulin. And this is actually a challenge for the globe, because many countries do not have the ability to address the needs with analogs. I think we need to find the right balance between protecting human insulin production while accepting that analogs are progressively also being widespread in the market, but trying to maintain that dialogue to have new suppliers on the market and drive the cost down so that it's affordable for your systems, for your countries, for the people who need to benefit from those drugs. Yeah, these are just examples of those protocols that you can find. And of course, you should not literally apply them. There is a law, I mean, many countries have expert groups that look at how you can tailor and adapt those protocols based on your context. Skip that. The model list used to be a very thick report every 2 years. It still is on a PDF, but you have also an electronic version, and I really recommend you to go on the website of WHO on that list. You can also find the indication, the information when it has entered on the list, and find additional element about what kind of presentation does it exist, and the general information of each of those drugs that are added progressively on the EML. The same for, and this is probably less known, but we have the same with the essential diagnostic list. And in particular, some areas are very important, just the simple glucometers, but more and more so as people are willing to monitor themselves, and self-care is an important development, how those diagnostics are also made available with quality insurance and with some recommendation about how we support countries when you have programs in place to purchase them, but making sure that the technical specifications are correct, and you have also some guarantee control about what you are purchasing, specifically for national programs in countries. We, Bianca has mentioned it, I think we have, with the private sector dialogue was one aspect of the governance, a lot of discussion with pharmaceutical companies. And this is not an open dialogue. It's a structured dialogue to be able to address the various elements of the pharmaceutical value chain, from R&D to the distribution, asking specific questions to companies about their contribution. The pre-qualification result that we start to register are some of the result of the discussion. The technology transfer that was also mentioned between two countries is another example, but we are trying also to make sure that we have tools to support this. So one aspect is the NCD medicine forecasting and quantification tools that we are trying to develop to help countries anticipate their needs based also on past consumption, but also on other methodological approaches in order to procure and anticipate their needs both at the national and subnational level. The second element that is in the bullet point is that, and this has been for 20 years a discussion, how the contribution of the private sector could be potentially registered. So this is a very tough discussion we are having with the private sector companies about being able to register their contribution and publish it so that people also know that this is in the public domain. Sorry, I'm running out of time. So this is just the information note about the linkage between diabetes and tuberculosis and how we can operationalize this need about screening from both directions and integrating those services. This is, I think, a very important point in particular for all the region and Mexico, is that often we are asked, the work that you are doing on diabetes is separated from obesity and not. And I think the operational plan and the acceleration plan address many aspects on primary prevention that are both important for obesity prevention, but also for most of the NCDs, including diabetes. But our colleagues are also much more now focusing on the service delivery model for obesity at a primary care level, and how you link this also with the existing platform of service delivery, including for diabetes. The first guidelines for the management of obesity for children are being finalized, and we will move also for the adult, which is more tricky as a topic about obesity management among adults. But we have also to make sure that those discussions, I think the fact that some of the countries in the region are really trying to adapt and integrate obesity and diabetes together, I think it's an important development. I just mentioned this, and this is again a plea for the region. With the hurricane, with the number of emergencies, you have the ability also to better address the need of people with NCDs during emergency. The NCD kit is, these are boxes that actually we sent at the forefront of any emergencies. We can pre-position them, like in countries that have hurricane. This can be put in hubs in advance of a hurricane season, so that when any crisis hit, people can maintain continuity of care with this hit. And there is a different modules. A module of insulin is a different one because it requires cold chain, and all those modules allow you to order them separately. Yeah, these are all the list of technical products that are in the pipeline. We have quite a lot on our plate for the coming 2 years and beyond. And I think Bianca has already covered some of them, so I will not go further in detailing them. But if there is any question, please come back to us. And with this, I would like to thank you for your attention.
Thank you to Dr. Slim for this presentation of technical resources of WHOs. Now, please welcome Ms. Silvana Liciani, Unit Chief of Non-Communicable Diseases, who's going to present Accelerate Actions in Primary Healthcare to expand and accelerate the integration of NCD services in primary healthcare. Good morning again, and thank you, Maria. It's great to know all the available resources and activities from PAHO. So thank you for your presentations. In this next presentation, I'm going to talk about from the regional office of PAHO's perspective, how we're implementing all the existing tools through a new initiative to improve primary health care, especially for diabetes and other non-communicable diseases. And this is going to be linked with the next presentation of my colleague, Dr. Carla Canini, regional advisor for PAHO. And from PAHO's perspective, we acknowledge that diabetes is one of the main non-communicable diseases, and it has a synergy and are based on similar strategies, similar to those applied to other non-communicable diseases. So that's how we can work together with the teams of other non-communicable diseases.
Esto no está funcionando.
Well, we know that non-communicable diseases is the leading cause of death in all the countries of the region, around 80 or 81% of all deaths, and actually premature deaths, people who are in their prime, that they are young, but they are suffering for non-communicable diseases. And when we see the ranking for all the Latin American countries, when we see the mortality ranking, we can see that there's around 300 to 100 people. Well, you cannot see here, but there's more than 800%. So you can see there's a huge mortality range related to non-communicable diseases, and actually Mexico is around a half, 400%. And why is there such a huge difference in these countries? Well, the risk factors for non-communicable diseases are related to health, but they're also mainly related to health systems and services, how they're providing the service to people suffering from this disease, how they're guaranteeing these diseases, or the lack of guarantee in these diseases, and how they decide how they're going to treat people affected by this disease. We have also established a goal for 2025. This is a global goal to diminish premature mortality in the region. So the goal is 25%. And we have come up with an analysis in the region where we establish how what's the trend in the region. These are some of the countries that are here in this hall, and what are the projections for 2025. And here you can see the probability of premature mortality, and you can see a prevalence for female, and in the continuous line you can see the projection for the country, but in the dotted line that's the goal that we want to meet. I mean, we can see that there are very few countries, maybe none of the countries in our regions that have achieved this goal or can achieve this goal. So, and this is something that we have to change. We need to increase our efforts in the public policies in the region, and we need to improve health services in the region also for non-communicable diseases. And to improve this agenda for NCDs in the Global Assembly, we have established global goals for 2030, which basically is a set of goals to reduce risk factors, but also we want to include actions to stop diabetes and obesity and increase access for medicines for diabetes and other diseases. And also, as we have already mentioned, we have relaunched the best investments to meet these global goals for these NCDs. So improving public policies to reduce tobacco consumption, diet, physical activity, primary health care, And here we include a list that are not only pharmacological interventions, but also other aspects for primary healthcare, especially focused for NCDs. And in Paco, we have a regional strategy that include everything, which basically are policies and multi-sectoral alliances, basically including all government sectors, civil society. Engagement is essential to change public policies. We also have actions to reduce risk factors, especially for obesity, and handling of ENT, especially for NCDs, in terms of care, and how we're making progress towards the global goals. We know all the gaps that we have to overcome when providing care, primary care for NCDs in all the countries of the Americas regions. There's very few control, very few actions, both for hypertension, cardiovascular diseases, and other NCDs. We need to improve the actions for health centers so that they can guarantee a safe treatment for people suffering from these diseases. We know that there are some challenges in terms of funding for healthcare. We need to update protocols. We need to access better technology and human capital. We also know that there are a lot of challenges, especially in rural communities that suffer from NCDs. And that's why this year, the executive committee from PAHO has launched an initiative for better healthcare of NCDs to reduce the gaps and challenges, improve the capacities for national, state, subnational ministries of health, so that they can accelerate and expand the provision of healthcare for NCDs and especially diabetes. And also we want to improve the capabilities of these services and the capabilities of the resources to monitor people suffering from NCDs. And this is based on a comprehensive approach. And this is not only from diabetes, even though this is our main focus of this day, but this is focused for other diseases, and this includes the heart approach. We want to accelerate and escalate the approach of what we're going to do for diabetes, but we also want to apply this for breast cancer and other types for cancer, asthma control, to stop tobacco consumption, alcohol consumption. We want to have a comprehensive package to treat NCDs, and we're working closely with the ministries of health. So first we asked them what are they doing with the heart initiatives, what are they doing with the initiatives to improve the healthcare. How have they assessed the needs and the gaps in the service so that we can accelerate it and expand it? We're also improving our communitary scope so that we can improve healthcare with better quality processes. We're also implementing training programs with the health staff. And only just very quickly, just to show you that we have some of the tools already available that you can use in your efforts, that you can use to improve diagnosis and care for NCDs. These tools are based on the PAHO framework for healthcare, and we want to use this framework to tackle these needs, to reduce the gaps, and to see what are the processes and the supply that we need to improve to reach our health goals. I have a very few time, but I just wanted to mention that we have a framework that we're going to implement for these efforts. We also want to increase communitary engagement. Also, the WHO and PAHO guides, which are going to be adapted to each country reality in the region. We also have a set of training courses that are online to train the health staff, especially for primary health care, because they're the ones that are mainly treating NCDs. And we invite you to use these tools. Another aspect is the strategic fund to improve how we provide care for NCDs. So basically, how we are going to guarantee universal access for everyone for treatments. And this is a joint effort where we want to guarantee an affordable price for all the countries in the region. And this is also an accompaniment process where they acquire the medicines. And we also have a diagnostics team that can help us in this matter. And I just wanted to mention that this is what we have included in these efforts, and we're facing challenges in the improvement of healthcare, but we have all the tools and resources to tackle the needs and improve the existing resources and healthcare in the region. So thank you so much.
We thank the presentation of Silvana Vigiani, and we invited Carmen Antini that will be presenting the situation of diabetes in the Americas region and the implementation of the Global Diabetes Compact. Good morning, everybody. Thank you for attending. Thank you for being here, and thank you for allowing us to share some of the reflections that we had about the patient that we all have, which is trying to provide a better health service. Let's see if it works. I think that it was already mentioned. Diabetes, unfortunately, in very short time, had an impressive progress prevalence, increasing our region from 5% to almost 9%, equivalent to 62 million people due to this disease. Unfortunately, this number is underestimated because in our region we have a 40% of people that do not know that they have the disease. In some other countries it's 60%. Therefore, if we do the numbers, 62 millions, it's really exceeded by the 100 million, and the figure expected for next year, it's going to be so high. This slide only to call your attention. These are the latest estimations that we have. But if you see, if you can count them, there are 28 countries in the region exceeding the regional average rate. So these countries have a diabetes rate that is higher than all the region together. What is this the result of? Unfortunately, we have the higher diabetes load because we are the region with more obesity. Therefore, we have this explosion combination. If we do not do something to control these risk factors, this is going to be a situation that will be drastic in some years. Let's see a little bit. What does it mean for the countries, for the region, to have this high number of people with diabetes? What you see in the slide, it's an analysis of the disease load, and we have 4 indicators in the screen. We have the standardized mortality rate, which is the number of years living with the disease, the number of years lost because of diabetes, and the rate adjusted with disability known as models. These estimations were done based on what we have in the WHO and the WHO, but we excluded the kidney chronic diseases because we also have the estimations. You can see them in our page, but we are just trying to hold your attention to this complication. Right now, we are concentrated only in diabetes. What can we see here? In the case of male, if you see, apparently, the mortality is mostly controlled at regional average because there is an annual rate with an increase of 1.2%. But as you can see that there are some red lines because it is not the mortality at this time. And that is not our highest problem, but the disability is a problem. It means that we are doing something that the people live more years, but they live more years, but not in good conditions. And that's what we have to prevent. In females, the same happens. We have an increase with 1.8 annually, which is lower than males, but the figure is still so high. But if we make the analysis at the sub-regional level that we have in the Americas, we find something very surprising. In the case of male, also shown with the red arrow, we can see that in the North American countries, US and Canada, they are increasing at 2.8% annually in disability. But unfortunately, in females, the same is happening. And what is disability? Well, they are amputated, they are blind. Why do we have this dilemma? Why do we have this big challenge to be faced? Well, I already mentioned part of it. We have a 40% of underdiagnosed people. Unfortunately, just Bianca and Silvana mentioned this, the availability of medicine and basic technologies for the diabetes control is not the optimum. We have to work very hard on this. And besides that, the professionals are not properly trained. There is something that in all the workshops that I teach, usually they are requesting for more training, and this is reflected in all the surveys received. Of course, if we have these challenges and if we have this gap in health, the health expense associated to diabetes will be exponentially growing. What I'm showing this slide are the results of the last survey made for the capacity of every country, 2021. What are we showing here? Well, 4 things. You can check all the results with all the details in our webpage, but although diabetes has a priority in theory but in all the countries, unfortunately there are only 7 of them that have a specific plans for the diabetes control, and 16 with some goals set for the specific control of diabetes. We can also see that only 19 out of the 35 countries analyzed have glucosylate hemoglobin to assess the metabolic control of patients. And that is one of the gaps that I think it's the most important. And the surveys for the population, unfortunately, we are facing that, but diabetes is a preventable and controllable disease. But in order to do that, we need to strengthen some aspects. What do we need to strengthen? Prevention, of course, diabetes, and also the risk factors. But besides with all the pathologies associated to diabetes, hypertension, obesity, lipidemia, physical activity, but we have also increase the screening. We must decrease the number of people not knowing their condition to improve monitoring and to improve the interaction between the different sectors. And now I'm going to show you a summary, which are the progresses that we have in the region for the implementation of the World Compact. And sorry, because when we work with different operating systems, some of the presentations are not well done. That happened to me. So I am asking you to use all your imagination when you see the slides. With the implementation of the compact in our region, we established 5 essential axes, which is assessment, research, and participation of the stakeholders, technical support, obviously, and to make communication, awareness, and education campaigns together with the mobilization of resources to ensure that we have the sufficient resources to control diabetes. What have we done in assessment? Well, we publish the links. The links are right. The images are not right, but the links are right. What can we see here? We publish the panorama of diabetes, which is a report of the situation of diabetes in the region, also a summary of the factors associated to diabetes. And recently we published this profile of the disease load for each one of the countries, both diabetes and kidney chronic disease. We also have a group of stakeholders from the WHO. We made already 2 meetings with a very good participation, with a lot of interest and a valuable cooperation. Recently, we made a webinar with the participation of all the stakeholders. Technical support is something that we are trying to maintain in all the countries permanently. For that purpose, we are setting different resources, and we are right now performing the guidelines for clinical practice for diabetes type 2, and periodically we do technical visits to the different countries. Regarding education, we published a couple of days ago a series of documents associated to self-management of diabetes. The first one is the care of food in people with diabetes, and this is part of the diabetic guidelines. And this is what I wanted to share. Thank you very much for the time. We thank Dr. Carmen Antini that presented the regional panorama and the implementation of the World Compact. And now we are going to welcome Luis Lopez de Araula from the Mexican government, presenting the situation of diabetes in Mexico and the strategies to prevent and control the disease. Thank you very much again. Thank you for taking away the air conditioning. It was really very cold. Thank you very much. Bianca, Slim, Silvana, thank you very much. I think that the presentations were very important. We are used after the pandemic to attend a lot of webinars, but the best thing is to see you face to face. Thank you for the opportunity. And I think that we are going to have 2 events after the coffee break that will be something about how to get closer to these technologies, medications, and the local experiences. I want to thank the people coming from the region. Thank you very much for being here. I think this discussion is very important to be considered from the different points of view we have. I think that these presentations provided us with elements to be discussed. I'm going to try. Right now, I am the under ministry. I was the director of Tenaprese before now, and Lopez Gatell invited me to participate in his team. It's precisely because diabetes and chronic diseases in general have been my academic approach. But I also have to recognize that when I went to Tenaprese thinking that the program, well, from the academy, I was seeing what was happening in the general program. and I was very attached to the diabetes program, trying to find why there was not really an impact. When I went to Sena Prese, I had to face the reality where it is quite different to understand from the academy or from the international agency's recommendations and to understand why things were not implemented and we didn't know about the issue. We really had a very low impact. I think that one of the problems we have is that we think that we have a very good experience and that we have very good models and that we have a very good units and that we have a pilot. But moving from pilots in the units to really have an effective coverage, which is the perspective that we must have in mind, we must not think that we already know how to do things. What we must understand is why we are not reaching 80% of people at least. Then we had a pandemic and all that, but I think that this is the approach that we have right now, taking advantage of the system's transformation, but also the primary health care to say, okay, this is what we have, and 40 years after, this is getting more important. And also to say, why are not we modifying the attention level or the first level attention? I think that we must modify it since the very basis, because it has a way to resolve these chronic diseases. And I think that we are just missing that we must understand that this must be a radical change and not only to adequate it. Here we have some of the aspects that we consider important. I think that it is important when we talk about the prevalences for the Mexican population. It's also important this change that we did in this government period to have a good health. And I thank the Public Health Institute because now we have these annual meetings, and next year we are going to have these estimations at the state level because in the past we had them every 6 years. But the last estimation in the 2022, we had this prevalence of diabetes globally, known or unknown, 18.3%, and that is going to be adjusted because we will have a variability according to the years. This is an estimation showing that we have almost 70 millions, but we have this 5.8% still with the prevalence of unknown people. But when we see the risk factors, which is, of course, obesity, we see this very high number where 1/4 of the population have obesity, and that is the element that is affecting prevalence. These are the mortality numbers 2021. When I was seeing these numbers, INEGI just showed the official statistics for 2022, but it was very interesting to understand that during the pandemic, when we had the COVID as the first reason for death, that pushing the higher mortality experience in this country and in other regions of the world where the chronic diseases, cardiovascular risk, diabetes, as the main diseases explaining these high numbers, especially in countries as ours. But even though we also saw an increase of diabetic diseases and due to hypertension and cancer diseases, where we had a very stressed system with the pandemic that was covering to a big level, not only the attention, but the prevention of diseases. We also had an increase of mortality due to diabetes. We can see that in these statistics, where we can see that the diabetes mortality, it was not the COVID that's in COVID, but this is only the diabetes deaths. It also depends on the methodology, because also the classification of what do you call diabetics death or cardiovascular or kidney diseases. Well, that is a description that we do not have a very clear international description. I would ask all the institutions to have a clear description of this, because in Mexico we have these two reasons for that, but there is a similar prevalence in other countries where diabetes is essential. Also, as it was already mentioned, diabetes as the main reason for disability as the main load, and this data shown mortality is not moving so much about the years with a disability. It's clearly what we can see in diabetes and in many other chronic kidney diseases. This is the ENSA noted data. These are the best estimations that we have, because sometimes some of the bias that we have from the same sector is playing with our data. It says, okay, what are we seeing in our patients and in our institutions? And this is very different to what we see in ENSA. If you go to the IMSS and you say, what are you doing? Well, they do have data, and they have data, and we also have data in the Ministry of Health, because they are seeing the group of people that they are taking care. In health, it's a very good advantage that you can go to the houses, but to see the reality, you always find a gap in there. That's why I invite to all the institutions, and I've been insisting on this, we have to use the INSANUT as the main performance data, because if we use our data, it's not going to be good. It is interesting, 87% have a pharmacological treatment. A question that we were analyzing from the academy is, when was the last time that your treatment was changed? And most of the patients, and we are talking more than 50% in diabetic patients, had the same treatment as the initial one when they were diagnosed. And that is talking about a big clinical inertia. We cannot only talk about the coverage of the medication, but we must see how are they modifying the drugs. Only 1/5 part with a glucosylated hemoglobin monitoring has at least one determination. There has been a transition. We are trying to accelerate it. We are discussing how much are we reaching with the point of health, with the monitoring and the machines that we have provided them with. But in the other side, I think that this is not the most economic and most efficient way to make the measurement of glucosylated hemoglobin. But we also have a monitoring problem with the complications, 13%. It is interesting. We have to add the disability years due to kidney failure, because we know that kidney failure, it's increasing a lot the number of years with a disability, and this is a consequence of diabetes. Less than 50% have people have the determination, and 15% had a remission of food. Because when we have less than 10% of people visiting the ophthalmologist, of course, we do have a problem there. We know in the system that we have to do that, but what do we do? They say, okay, let's have mediatic cameras, but there we also found this laser treatment problem. So they say, okay, we are going to replace that, and let's have mediatic cameras, and let's try to find out in the first level. This is a systemic problem. If we do not change the system, we cannot do only what we have to do in the first level. We have to modify that. And this is clearly seen in the care estimation. This is the data that we did using the ENSA data with the 2021 with 21.1 million living with diabetes, out of which only 70% were diagnosed, that they already had a treatment, but in control were only a small part of them. So in the program, we decided to approach it from 2 points of view. So one was a prevention to transform the health system, where we have been acting a lot, but also with other models. I think this has an approach more taking care of a person. I think that we must put aside transforming the diet environment, and this is a public model. Is within the past vice that we just had. Silvana talk about this prevention. This is very important, and this is a main factor where it's not only the states of the public policy are fighting because of the conflict of interest that we have in the government, but we must also ask the international agencies to do as appropriate because they are our way, so that we can move our national politics, because they have to change that. And this is part of what we are doing. In the attention model, we are finding that detections and interventions going through control. And here we have different factors. Every time I talk about this, they said, okay, I think that we are improving in our risk factor questionnaire and for detection, but always, and this is a discussion, is how many detections did you do? That is an indicator, and we have a very good detections number in all the states. When we go to Sanuta, we already have this 30%, but clearly we are not reaching people. Yes, we had improved, but we have to reach this 80%. The WHO say that they got an 80% diagnosis rate. This treatment requires, of course, and I'm going to talk about this with the data systems. This is the care system. We have a very big difference with the mutual groups. If we see in Sanut and we ask the people with diabetes, have you ever been in a mutual aid program? 15 to 20% have been there, but who stay really there, because this is a cost-effective treatment, and there are not too many remaining there. So we must not have these mutual aid programs, because if we do, they cannot be escalated to a big number. Something that was really important was to improve the protocol factors, where we have a conflict of interest with the industry, and we must have a state mechanism to take care of these care protocols. We are trying to have protocols and treatment both for hypertension and diabetes, but we must have options, and also to insist in the modification and ongoing assessment in order to move away this inertia. Something that was very important for diabetes, as well as in hypertension, and that's what hearts say. We can say that 80% of the patients need a double therapy since the very beginning. That was a change in the total paradigm, in the way the treatment was laid. In diabetes, we hadn't changed that, and I am not pushing to make a change, but we must, I think that the monitoring of all the changes in the treatment must be more frequent as originally happened. And this is part of what we are currently promoting, and we are aware of this optimization triple. We need a group of people saying which is the most appropriate treatment, but then we must do the population optimization, where we have the public health center and say, okay, this is the expert's opinion, but what can we do to have a coverage for all the people? Where are they? What kind of conditions? Who's taking care of them? Are they close to the health system? Then we modify the demand and create a population demand. The idea is to say the whole sector, and that's what we are doing. The whole sector has the same demand, and now we have the triple optimization, the second feature, which is getting more points and decrease the cost. And that is really very hard. And I think that's why I have this disagreement with the insulin because according to myself, we know that it is very costly. We had a shortage of the NPH insulin, but we also think that the treatments, when they are brand new, they must be quickly integrated. Iglatina, it's a novelty. It has some advantages, but it does not justify the price difference versus the human insulin. So we must be very careful when incorporating new treatments, and that's part of what we are doing with the optimization. We also said, because we had a model that was not telling us how to do things that they just mentioned, how to implement it. It has an implementation point of view, not necessarily with the good practices. And we have to incorporate this model. And right now we have this last package where we are transversally incorporating diabetes, where we have a lot of indicators. What I want to say is, yes, okay, we are in an ever-changing condition. We must focus our efforts on the primary healthcare. That's why IMSS Bienestar, where they are starting to operate, but also to invite the states where we are operating. And I am going to say this as my last message. We have been so concerned about these effective, efficient models that everybody say, such as the UMEMES, the specialized units. But please, I have to ask you all to recognize that these specialized centers, UMEMES, take care only of 5% of the people. If we have a model that it's working, but it cannot be escalated, we must find another option. This is not the political willingness, invest money to reach it 100%. It is clearly a model that we cannot be using if we cannot escalate and replicate it. Here we have to see what is happening in the other 80% that is being taken care by general practitioners, general doctors at the first care level that they require change of their model. And we are also inviting you to discuss all that. I thank you very much. I think that you more time than I had. I've seen the sign several times, but thank you very much.
Thank you, Dr. Reed, for your presentation.
Let's take a 15-minute break, a 5-minute break. Hi, please take your seat. We're about to restart.
Hola, hola.
Bienvenidos de regreso todos. Retomamos nuestras sesiones con el
Welcome
siguiente
everyone
panel
back again.
sobre
Let's
avances en el
restart
control de la
and
diabetes,
continue with
experiencias
our
exitosas en la región de
presentation.
las Américas. Como moderadora,
Advances
tenemos a la doctora Vivian Pérez, asesora de enfermedades
in
no
diabetes
transmisibles
control
para la
successful
Organización
experiences in
Panamericana de
the
la
region
Salud de
of
la
the
Oficina de México.
Americas. The
Sí,
moderator
muchas
is
gracias,
Dr. Vivian
Mariana.
Perez,
Buenos
advisor
días a todos y
Medical
todas.
Disease
Y
and
bueno, no
Mental
solo los que
Health
están
for
presentes,
PAHO
sino
Mexico.
a todas las personas que nos están
Welcome
acompañando de manera
everyone,
virtual.
not only the
En la
ones that
primera
are
parte de
here
este
physically,
evento
but
se
the
presentó
ones that
todo el
has joined
contexto
us
de la
virtually. In the
diabetes, cuál es
first
la gran carga que
of
significa
the
tanto de
session,
morbilidad,
we
muerte
will
y
introduce
discapacidad. Y cuáles
diabetes,
son los
especially
principales
in terms of
desafíos que tiene nuestra región y todos
mortality,
los países en general
comorbidities,
para abordar
challenges,
este gran
and
problema de salud
solutions, and
pública,
what are
como
the
es tratar de
efforts from
prevenir
the
todo el
countries
riesgo que
of
tiene
the
que ver de
region
riesgo para la
to
diabetes,
tackle these
garantizar el diagnóstico
issues,
oportuno
to
y el tratamiento que
guarantee
permita
opportune
garantizar el control
diagnostics
metabólico y evitar de esa
and
manera las
guarantee
complicaciones.
treatment
En este panel que
to
tengo el
avoid
placer de moderar,
complications. In this
quiero
panel,
compartir con
which I'm
ustedes, que
the
puedan compartir los
moderator of,
panelistas que me acompañan, tres
would like
experiencias
to
de éxito que ha
introduce,
tenido
I would
nuestra
like to
región de las
ask the
Américas
panelists
en
three
cómo han avanzado estos
experiences
países
in the
en el
region of
control
the
de la
Americas
diabetes.
and
Y
how they
como
have
primer
made
panelista, quiero
progress, your
presentarles a la
countries,
doctora
on
Julieta
diabetes
Méndez,
control.
coordinadora
And I
del
would like to
Programa
introduce
Nacional para la
Dr. Julieta
Prevención y el Control de las
Méndez,
Personas con
Director
Diabetes
of
mellitus del
Prevention,
Ministerio de
Control
Salud
and Care
de
of
Argentina.
Diabetes mellitus of
Adelante,
the
doctora.
Ministry of Health of Argentina.
Bueno, muchísimas gracias por la invitación.
So thank you
Muchas gracias por
for the
estar
introduction.
compartiendo todas estas experiencias en este día tan especial y por
Uh,
estar
I,
aquí en esta
I'm very
hermosa
pleased
ciudad
and I feel very
y
honored to have been
en
invited to
esta
share my
ciudad tan
experiences
importante.
in this very
En honor al
enriching
tiempo, ya,
session.
no sé, vamos a empezar con la
And
charla.
without further ado, I will start with my presentation,
No me está pasando, pero no sé si soy
which
yo.
is not that
¿Para allí?
one.
Bien, ahora me adelante. Bueno, lo que vamos a estar presentando es el proceso
So
de
what
la
we're going to
elaboración de la guía
present is
clínica
the
de diabetes
elaboration
mellitus tipo
process
2 de
of
Argentina.
clinical pathways for diabetes
Entonces, el
mellitus
primer
type
paso que
2
tuvimos que
in
tener, que es
Argentina. So the
fundamental,
first
el
step
compromiso para desarrollar
that
la vía
we
clínica. En
had
nuestro
to
país, la
introduce was
diabetes es una enfermedad
the
prevalente.
commitment to
Uno
develop
de
the
cada 10
clinical
adultos la
pathway.
presenta y
The
tenemos
diabetes
lamentablemente un
mellitus is
subdiagnóstico que ronda alrededor
critical
del
in Argentina. 1 of
40%
5
y, como observan acá, también un
people,
control
adults,
inadecuado.
present that,
Por eso
and
es que adquirimos el
this is
compromiso
reflected
de
in
mejorar esta
how we do
situación
not
a través
better control,
del Plan
and that's
Integrado de
how
Enfermedades No
we have
Transmisibles y
to
la estrategia HERST, que
improve
como primera instancia
NCT
necesitábamos la vía
strategy
clínica
and our
de
heart
diabetes mellitus tipo 2.
strategy,
El
which is going to
segundo,
be
si bien yo el
used
segundo,
for the
tercero y
clinical
cuarto
pathway
paso a
for
efectos de la
diabetes
presentación
mellitus
los
type 2,
presento en forma
and
separada,
as the
en
second
realidad se
step
dieron casi
in the
simultáneamente.
presentation,
Como van a
even
ver,
though
el
this
segundo
is
paso
an
es la
individual
elección del
step,
equipo
they were
elaborador.
performed
Estaba
almost
integrado por
simultaneously,
la
which
doctora
is
Liliana
selecting
Medveski
the
y
team,
quien
which
les
was
habla,
Dr.
que
Elena
íbamos desarrollando
Melevsky,
borradores. A medida que los
who
íbamos
was in
desarrollando,
charge of
teníamos la asistencia
drafting
técnica permanente
the
de la
documents
OPS a
of
través de la doctora
monitoring the
Carmen Antini,
permanent
que tuvimos múltiples
aid of
reuniones y
PAHO
también
by
algunas ha
Dr.
participado
Octel,
el doctor
with whom
Rosende,
we
Andrés
held
Rosende.
several
En esas
meetings, and we
reuniones
were also
íbamos
joined by
presentando
Dr.
los
Manuel
avances
Rosandes.
para
And
poder
during these meetings,
analizarlos,
we presented all
resumirlos, porque
our
esa fue una tarea
progresses or
muy importante, el
advances.
resumen, ajustarlos y volver a continuar con la
Basically,
tarea.
we presented
También las
executive
versiones
summaries
preliminares
that
las íbamos
were
presentando
adjusted
a nuestras
and we
compañeras
also
del área de
presented the
guías de
tests
práctica
who were,
clínica. El
presented
tercer
by
paso
our
era la
colleagues
revisión
from the
de la
clinical
bibliografía, la búsqueda de evidencia,
teams.
y acá
The next
nosotros
step
teníamos una
was
importante
the
fortaleza,
cross-check
ya
of
que
the
teníamos las guías de práctica clínicas
references.
actualizadas en la
And this
temática.
was very important
Las guías
because we
nuestras son de alta
had
calidad
clinical
metodológica y de
practice
transparencia,
guides
ya
that were
que a todos los que
updated.
integran la guía, participaron en la
This
guía,
included
les hacíamos
transparent
firmar previamente a la tarea
information
y decir si tenían o no
based on
conflictos de
an
interés.
informed consent
También es importante
signed by
destacar que
the
en la guía
participants
teníamos
of the
el panel
study.
interdisciplinario
And
de
it is also
consenso, donde
important to
participaron
highlight that we have a
distintas
consensus
disciplinas
panel
y
where we
especialidades, como
included
así también
different
están la
disciplines and
participación de las
specialties
asociaciones que representan a las personas con
different
diabetes. Y
organizations that
también el panel
represent
federal de
people suffering from
implementación, donde
diabetics,
está
and
integrado por todos
also
los
the
referentes
implementation panel
jurisdiccionales de
that
las 24
was
jurisdicciones en las que se
made up
divide
by different
Argentina, ya que mi país
government and
es un país
judicial
federal, de estructura federal. Entonces,
organizations
¿esto por qué fue
from
una
Argentina,
importante
which
fortaleza?
is
Porque ya
divided
teníamos
in
discutida toda la
different
evidencia
states, federal
y
states.
consensuada las
So based on
recomendaciones de
this,
nuestras guías de
we
práctica clínica,
included the
lo que agilizó el
recommendations
consenso de la vía
that were
clínica.
included in the clinical
El
practice
cuarto paso
guides,
era
and this is
verificar la
what
existencia de otras
facilitated
vías
all the
clínicas,
efforts
porque
regarding the
si las
clinical
hubiera, las
pathway.
íbamos a evaluar,
The next
obviamente,
step
para
was to
aprovecharlas.
verify the
No
existence of
encontramos
other
una vía
clinical
clínica en esta
pathways.
temática,
In this
pero sí
case, we
teníamos la vía
didn't
clínica
found
que
any that
desarrollaron
had to
nuestros
do with
compañeros del
this
programa de
issue, but
cardiovascular
we also
sobre
did
hipertensión arterial.
find a
Entonces nos
clinical
facilitó
pathway
pensar
for
cuáles eran los componentes que nosotros
cardiovascular
queríamos que
issues.
estuvieran
So
en
based
nuestra
on this,
vía
we
clínica
had
de
to
diabetes
find what
mellitus.
were the components that we wanted to
Posteriormente
include in our
realizamos
clinical
la
pathway
vía clínica
regarding
preliminar. El
diabetes.
proceso
After
nosotros
that,
lo iniciamos a
we
finales de marzo
elaborated
con
the
una primera reunión
clinical
con Carmen y
pathway,
Andrés,
the
y
preliminary
posteriormente la
pathway,
versión
which
preliminar la
was
tuvimos a mediados de junio.
performed at the
Allí
beginning of the
estuvimos
year,
en
and
condiciones de
we fully
presentarla
drafted
a la
it at
Sociedad
the end
Argentina de
of
Diabetes
June.
para tener el
After
consenso y
that,
los
we
ajustes
presented
pertinentes
that to
que
the
realizamos,
Diabetes Argentinian
porque la Sociedad Argentina de
Association so
Diabetes
that
es un
they
actor
could
clave
review that
en nuestro
for
país,
changes and
y
adjustments.
también
This organization is a
venimos
key
trabajando en forma articuladamente
stakeholder
desde
in
hace muchos
Argentina,
años.
with whom
Posteriormente
we
a
have
los
been
ajustes
working
realizados
for
allí,
several
ya
years.
estuvimos en
After the
condiciones
pertinent
de presentarla a un consenso
adjustments,
ampliado,
we
en los que
held a meeting
participaron,
to
como ves,
present
nosotros
this
contamos con la
document
Comisión
to
Permanente Asesora de Diabetes,
committee,
que está
which
representado por
basically
los
is
referentes de
the
las jurisdicciones,
advising
por, como
diabetes
vemos ahí,
committee, which
sociedades
is made of
científicas
by
afines,
different
la academia,
scientific
las
organizations in this
asociaciones de las cuatro
matter,
principales
the
representantes
academia,
de personas con
and
diabetes
the
y la
organizations
Superintendencia de Servicios de
representing
Salud,
the
porque
main
regula a las obras sociales y medicina prepaga.
diabetes
También
related organizations as well
convocamos
as
a
other
otras
experts.
instituciones
We also
y
included
estructuras
other
ministeriales. El
institutions and
consenso se
ministerial
logró
organisms.
y el 24 de agosto
Once
pudimos
we came
publicar
up
en
with
nuestra
a
página web
consensus,
la
on
vía clínica
August
ya
24th,
finalizada y
we
consensuada, como
published
ven,
the
en nuestro
clinical
ministerio.
guide
Y
that
como
you
ven
can
también,
see
tener la vía
available
clínica
in
es
the
uno de los
ministry.
impulsores de la estrategia HEART
Having this document is
para
one of the
poder llevar
drivers
la
of the HEART's
implementación de la misma.
strategy that would result
Entonces,
in the implementation
resumiendo,
of this document
nuestras
also.
fortalezas,
Based
tenemos
on these
un marco
efforts,
normativo
and
muy
once
amplio
we
y esto
discover our strengths,
nos
we
avala
came
al
up
programa
with a
para tratar de
wide
traccionar la adecuada atención
normative framework
y la adquisición de
that would
medicamentos e
allow
insumos
us to
esenciales para las
expand
personas con
healthcare
diabetes.
and the
La
procurement
articulación y el
of
trabajo en conjunto que venimos
medicines
realizando con
and
las
essential
24
supplies
jurisdicciones
related to
también facilitó
diabetes.
y la
Also
articulación
working
con
with
atención
different
primaria de la
judicial
salud
organizations
ya
and other
que
organizations for
ellos son el
primary
brazo efector de todas
healthcare,
nuestras acciones que
not just
hacemos
in
para
these
poder llegar a
efforts
la
because
capilaridad
they
de
are
las
the
jurisdicciones.
baseline
También
in
la
working
academia, las
and
sociedades
reaching
científicas y las
all
asociaciones de
in
personas con
terms of
diabetes que
jurisdiction. Also
pertenecen
the
a la
academia
Comisión Permanente
and
Asesora de
people
Diabetes
suffering
y, por
from
supuesto, el
diabetes
programa ya,
helped
el
us
recorrido
in
ya
these efforts
realizado por
and
el programa
also
de cardiovascular en la implementación de la
based on the
estrategia HERS.
cardiovascular program
Tuvimos
related to
desafíos.
this
Los principales
strategy
fueron
was part of
seleccionar
this
cuáles
effort. We
eran
faced some
las
challenge. On the other
recomendaciones que
hand,
queríamos que
one
estén
of them
en nuestra
was
vía y
determining what
la
were the
capacidad de resumen,
recommendations that we
logrando un
wanted to
adecuado
include in
equilibrio
this
para
document
no eliminar
that would
ninguna acción
ultimately
que debe ser
balance the
necesaria,
content
básica, que esté plasmada
without
en
getting
la guía
rid of
clínica.
any important
Y la
aspect
edición
in the
fue
clinical guide.
un desafío muy importante. Tuvimos varias
The
reuniones de edición para
issuing
que
the
todo pueda
editing this
estar
document was a
plasmado
very
en una
important
hoja
challenge. We
A3
held
que sea legible
several
y poder
meetings
digamos,
regarding
exponerla en los
editing.
consultorios de
We
todos
had
nuestros
several
CAPS. Los CAPS son los
regarding
Centros
the
de Atención Primaria de
A3
la Salud.
pages
Y
that could
también
be
en el
pertinent to the
consenso con estos
format and
distintos
that could
actores
be
tuvimos que hacer una
available
jornada
in the
similar a
health
esta
centers.
para
After
poder
that, we
hacer
held
los ajustes
other
necesarios
meetings
y
so that we
tuvimos
can make the
que
pertinent
asumir compromisos con ellos para
adjustments
poder
that
llegar a
were
la versión final.
necessary
Uno de ellos
so that
fue
we can reach the
realizar
final
una
version of the
vía
document.
de
One of
prediabetes. Nosotros
those
propusimos
meetings
realizar en realidad una
regarding
vía de prevención de enfermedades no
a prevention
transmisibles. Y
pathway
la otra
regarding
fue
for
que durante las
diabetes,
capacitaciones
for
de la vía clínica
NCDs,
realicemos
and
también
for
la
NCDs,
capacitación
which
sobre
we
los
already
distintos tipos
had.
de diabetes
And during
y
the
el
clinical
diagnóstico diferencial
reviews,
para que no ingrese en la vía
we
clínica de
try
diabetes
to
mellitus
include the
tipo 2
different types of
una persona que tiene
diabetes,
diferente tipo
but
de
we also
diabetes. Y
determined
el gran desafío
that
que estamos en este momento
people suffering from type 2
implementando,
diabetes
teniendo,
were going to
es
be
la
included, and
implementación
not all
no
the people
solamente
suffering
de la
from
vía
other
clínica,
types of
sino
diabetes.
de la
We
estrategia
also
HERS-T que ya
determined
estamos
that
iniciando
this
entre
were going
jurisdicciones.
to
Y
be
finalmente,
included not only
la
in the
diabetes
clinical guide,
es
but
una
in the
enfermedad prevalente
HERS-free
y la mayoría de
strategy.
las personas, el 80% de
Ultimately,
las
it's
personas pueden
also
ser
important to
tratadas en este
mention
primer
that
nivel de atención, por
TM2
lo
is a
tanto lo tenemos
prevalent
que fortalecer. Es
disease, and
necesario
most of
realizar
the
un
people
correcto y
could be
oportuno
treated with
diagnóstico
primary
y
healthcare.
control
It is
glucémico y de
necessary
todos los
to
demás
make
factores de
a
riesgo
proper
cardiovasculares. En nuestra
and
vía está la
opportune
parte de
diagnosis.
medir la presión
So
arterial a todas las
we
personas con
have
diabetes. En nuestro
to
país, 7 de cada 10 adultos que
also
tienen diabetes
perform
tienen
a
hipertensión
glycemic
y también la parte de
control
las estatinas,
for
al igual
people
que lo
suffering
mencionaron
from
anteriormente.
hypertension,
Y
and
también el screening y la
which
detección de
are
las
7 out of
enfermedades, de las
10
complicaciones
people suffering from
microvasculares,
diabetes.
porque al igual que
And
presentaron
also
acá en
we need
México,
to
a nuestros
control
pacientes solamente 3 de cada 10 se les revisa los
cardiovascular
pies en un año
diseases,
y
because
solamente
just as
4 de cada
Mexico,
10
1 out
se
of
les
3
realizó el fondo de
are
ojo. Por eso
have a
también
checkup
recordamos en la vía,
in terms of
y
feet,
esta vía que
and
está
only 1
preferentemente
out of 4
para primer nivel de
have
atención,
eye
también
checkups.
tenemos un
So
apartado
in the terms of
donde les
prevention, we also
recordamos
have a
cuáles son las
section where we
instancias
remind
para
the
la derivación
patients
oportuna, ¿no? A un centro
how
de
can
mayor
we
complejidad. Y suponemos que
channel
utilizar
them
estas herramientas disponibles,
channel
como
them
es la vía
properly
de
to
práctica
health
clínica que
centers,
nos
and
estandariza
also we
y
need to
optimiza
use
nuestra
the
atención diaria,
available tools
impactará
to
en la disminución de la
optimize our
morbimortalidad,
daily
pero
practice
bueno,
that would
hay que medirlo.
impact in
Así que
diminishing
muchísimas gracias.
morbidity and mortality, and how we're going to measure this decrease. And that's it. Thank you so much.
Muchas gracias, doctora Julieta.
Well, thank you
Y
so
solo
much,
comentarles,
Dr.
como bien
Juliet,
refirió
and
la
I would
doctora
just like
Julieta,
to mention,
que
as
los 3
Dr.
países que hoy nos
Julieta
acompañan y que le van a
that the 3
presentar su
countries
experiencia
that
están
are
implementando
joining us
HERS.
today
Actualmente en la región
are
de las Américas,
going to
33
share the
países
experience with
implementan
us, are
la
implementing
estrategia
the
HERS
HERS strategy.
y, como bien nos
Currently,
presentaron
23
anteriormente, es un
countries
recurso de que dispone
are
OMS y
using the
OPS
HERS
para
strategy,
mejorar
which
la
is a
atención
tool
de
that
las enfermedades
WHO and PAHO
cardiometabólicas cardiovasculares y del riesgo cardiovascular en un primer nivel de atención. Y creo que es un punto muy importante que le ha permitido también a estos países avanzar con una vía clínica para diabetes, de manera que puedan darle un abordaje más integral en el primer nivel. Y nuestra segunda panelista, que es la doctora Andeli de la Rosa, jefa del Departamento de Enfermedades No Transmisibles del Ministerio de Salud de República Dominicana.
Non-communicable diseases for República Dominicana.
No sé si está mi presentación. ¿Me escuchan? Okay.
You hear me?
Yeah. Ok, ahora sí. No se ve qué es la pantalla, pero... Bueno, primero muchísimas gracias.
So first of all, thank you so much for inviting us. It's a great honor
Sabemos que
to be
todos
here.
nosotros en los países de la región tenemos actividades diferentes el día de hoy,
We
¿no?
know that
Actividades de
all the
diabetes.
countries
Yo
of
sufro también
the
porque no estoy en mi país, pero estoy feliz
have
porque estoy aquí
different
con ustedes
diabetes
presentando
related
este gran avance, como
activities,
decía, ¿no?
but I'm very happy to be
Este
here
paso
with
que ha dado
you
la República
and
Dominicana
share
con
with
otros países de la
you
región en
the
avanzar
big
con
steps
su vía
that
clínica.
Dominican
Antes de
Republic
comenzar un
has
poquito,
made
esta es la
in
tendencia
terms of
demográfica
diabetes
de la República
control.
Dominicana. Tenemos adultos mayores, no
Before I
tenemos
start,
mucho en comparación con otros países de
the
la región, alrededor de
populations are
1.200.000
elders.
personas.
We have around
Tenemos,
1.2 million
sabemos, y lo dijo la
people,
doctora Silvana, la
which
primera
is
causa de
very
muerte en todos
few
los países y discapacidad
compared
en
to
todo el
other
mundo.
countries
No,
in the
no me voy a
region.
detener ahí. Es un problema serio de salud pública, con
This is a
82%
serious
en
public
países de bajo y
health
mediano ingreso, como
issue
el mío,
with
como República Dominicana.
82%,
Aquí tenemos unos datos de la
especially for
República Dominicana donde vemos que la
countries like
diabetes,
Dominican Republic, which
las muertes por
low
diabetes
and
están
medium
alrededor de unos
income.
3.7%
In Dominican
aumentadas, como
Republic,
decimos por
you
ahí.
can see that
Tenemos
the
un
average death
44.3%
rate
de esas muertes que se
3.7%,
catalogan como prematuras, y diabetes está alrededor de un 13%.
43.7%,
En la población dominicana hay un
44.3%
33.5%
are
que no sabe que padece
premature.
hipertensión arterial.
33.7% do not know
Para
that they
entender un
suffer from
poquito, la
hypertension,
República
high
Dominicana,
blood
le traje esta
pressure.
imagen, es una imagen
Just a
del
little
Plan
bit of
Estratégico
context.
Nacional de Salud de la
Dominican
República
Republic,
Dominicana.
this
Es
is
una
a
imagen de
draft
cómo más o menos
of the
funciona el país.
National
Evidentemente
Health
tenemos la
Program in
estrategia HART,
Dominican
que es
Republic,
única para
and
los
this is
países,
basically
pero
how
la
the country
implementación de la estrategia
functions.
va
This
encaminada a
is
cómo son los
different
sistemas
for
de salud de
different
los
countries,
países.
but
El
basically
sistema de
this
salud
is
de la
based
República
on the
Dominicana
same
tiene un Ministerio
health
de Salud
strategy from
Pública,
other
un
countries.
ministerio que es rector de las
Dominican
entidades
Republic
públicas y
has
privadas, y
a
tiene un
public
Servicio Nacional de Salud
ministry,
donde se rigen las
and
partes o la parte
they also
hospitalaria y el primer
have
nivel de atención.
an
Pues
agency
entendiendo
that is in
esto y
charge
sabiendo que
of
tenemos que trabajar en
providing public
equipo, que
health
tenemos seguridad
care.
social, que tenemos
So we need
otras
to,
entidades,
based on this,
lo
we
más
need to
importante de
work
entender en República
together.
Dominicana que
We
como
need to work
no
with other
somos, no
entities.
llegamos a
It is
12
also
millones de
important
habitantes,
to
tenemos
understand
11
that
y algo millones de habitantes,
we
pues
just
tenemos
have
una rectoría y tenemos un servicio
11
para la parte
million
pública.
inhabitants in
Esta es una
Dominican
foto de una de las
Republic.
primeras reuniones, ahí está Carmen.
We don't have a lot
Está
of
Andrés. Tengo que
services
decir que la
provided in
construcción
terms
de la vía
of the
clínica
audits. This
de
is a picture of
nosotros,
one of the
y
first
creo
meetings. This
que
is
puedo decir un
Carmen.
poco diferencia a
And
Argentina, es que nosotros desde
what
el inicio trabajamos en
differences
equipo
from
con las sociedades
Argentina, for example, is
especializadas desde el
that
Ministerio de
we
Salud
work
Pública,
with
ya que
specialized
tenemos
entities,
no guías de práctica
including
clínica,
the
pero sí
ones
tenemos
from the
protocolos
Ministry of
abordados en guías de
Health,
práctica
and we
clínicas basadas
already
en la
had
metodología GRADE.
protocols
Entonces,
based
sí
on
teníamos un
clinical
protocolo de
guides,
diabetes,
based
tenemos
on the
protocolos de
GRADE
diabetes, y se nos fue muy fácil
initiative.
con
So
estas
we
entidades, con las
already
sociedades
have
especializadas,
drafted
iniciar la
diabetes
consecución de la vía
protocols. So
clínica. Y debo de
that's why it
agradecer
was so
muchísimo
easy to
a
start
Carmen y Andrés
working with
por todo el
these
apoyo desde el inicio en
entities.
la
And I would
consecución de la
like
vía
to thank
clínica
to
del
Carmen
país.
and the rest of
Así
the team
comenzamos.
for
La voy a
working
pasar
with
rápido
us
porque
from
estas
the
fueron las
beginning.
presentaciones de
That's
cómo
how
comenzamos con
we
la vía
started.
clínica,
I'm
cómo
going to
comenzamos
take a little,
con
I'm not going to go into detail
pues la
on this, but
integración,
this is
¿no?
basically
De
how we
cómo íbamos
started
modificando paso a
integrating
paso. Antes
the
teníamos
programs
esta
and the clinical
propuesta y luego
guides.
entonces
These are
fuimos
the step a step
modificándolos.
of the
Ahí está
process on
paso
these
a paso por
proposals
el
and the
ABCDE de la vía
modifications.
clínica,
This is every
el
stage of the
tamizaje,
ABC of the
y aquí
clinical
están las
guide, the
metas de
screening
control
as
de peso.
well. These are the
Estas
goals,
son
the weight control
algunas, y voy
goals,
a decir
and
algunas, pero
this is
algunas de
some
las
of
entidades que
the
apoyan
desde el inicio la vía clínica y la estrategia HEARTS de manera general, la estrategia HEARTS-D en la República Dominicana, Hospital General de la Plaza de la Salud, la Sociedad Dominicana de Endocrinología y Nutrición, Sociedad Dominicana de Nutrición Clínica y Metabolismo, Sociedad Dominicana de Diabetes y Nutrición, evidentemente el Ministerio de Salud Pública, la Organización Panamericana de la Salud, el Instituto de Nutrición de Centroamérica y Panamá, INCAP. Todas estas personas están siempre desde el inicio, han estado siempre en la consecución de la vía clínica y otras personas, ¿no?
This has been working with us from the
Igual, como dice mi predecesora, nosotros nos apoyamos mucho en la vía clínica de hipertensión que está actualmente siendo implementada en la República Dominicana en todos los centros de primer nivel de atención. Es una vía clínica que Mérida ha tenido éxito el hecho de que la vía clínica en el primer nivel de atención sea fácil, sea digerible, que tengan los tratamientos que están disponibles en el país y que los médicos del primer nivel de atención, no importa que no sean especialistas, puedan entender y trabajar en base a una atención simplificada. Aquí está el protocolo simplificado de o lo que le llamamos la vía clínica ya finalizada. Aquí no se ve, no sé por qué, pero bueno, ahí más o menos está, esta es una versión, la próxima versión es que no se ve. Pues es una versión un poco mejorada de hace unas semanas con el equipo de Washington que tuvo unas recomendaciones, la adoptamos, la vía clínica va a ser lanzada oficialmente el 23 de noviembre de este mes, estábamos esperando presentarla aquí, es esta, no sé por qué se ve en negro, pero bueno. Debo decir que la vía clínica de diabetes tuvo mucha suerte este año. Nosotros, aparte de reuniones de la brecha que tenemos en HEARTS en el país, creo que todos los países cuando hablan de HEARTS tenemos la brecha de medicamentos, y no voy a dejar esto porque tenemos otro bloque de medicamentos. Es el bloque, es el problema del acceso, ¿no? De que no tenemos medicamentos disponibles. Hicimos reuniones y viendo la situación con HEARTS, que nos ayuda a medir qué nos falta para el control de la hipertensión y la diabetes, qué podemos hacer para abastecer el país en aquellas regiones o provincias donde hacen falta medicamentos de hipertensión y diabetes. Aquí, en esta foto de acá, ahí está el equipo que este año, justo este año, en este mes pasado, en unas semanas, acaba de actualizar el cuadro básico de medicamentos esenciales de la República Dominicana basado en el cuadro básico de medicamentos esenciales de la OMS. Eso incluyó muchísimos medicamentos importantes para la diabetes e hipertensión, que estábamos muy atrasados según las evidencias con relación a esto, y esto va a permitir que estos medicamentos para el 2024 sean comprados con sea el fondo estratégico o sea otros mecanismos de compra que tengamos en la República Dominicana.
Procurement mechanisms such as the strategic fund in the Dominican Republic. So that's it. Thank you so much.
Muchas gracias, doctora Andelis. Y solo comentarles que veo dos puntos de contacto en las dos presentaciones, las dos experiencias que nos brindaron Argentina, tanto Argentina como República Dominicana, cómo han adaptado a su contexto la iniciativa HEARTS. Y creo que ha sido importante para la construcción de la vía clínica de diabetes esta referencia de la vía clínica de HEARTS que ya disponen los países, y también han mencionado las dos ese trabajo colaborativo con otras instituciones, tanto de la sociedad científica, la sociedad civil como tal, y también otras instituciones de gobierno para poder avanzar desde la vía clínica. Y nuestra tercera experiencia es el doctor Henry Pérez. Él es el representante del Programa Nacional de Salud en el Adulto y el Anciano del SENAPRESE, de la Secretaría de Salud de México. Adelante, doctor.
From the Ministry of Health of Mexico. Welcome, doctor. Thank you for the invitation. And in the case of Mexico,
se centra en la población que no tiene
acceso a seguridad social. On vulnerable population who don't have access to this type of services. They don't have access specifically to social security.
En todo el país, con la población que no tiene derecho a
What I'm going to show you is the population most
Vamos a
vulnerable
revisar
to
los
this
dos
lack of
casos que hemos
social
ido
service. And we're
trabajando,
going to check
más bien
two
que estos
cases
estados, Yucatán y Chiapas,
in
han
which
tenido un
we
trabajo
have been working.
acelerado,
In this
por así
case, are
decirlo, han tenido
Yucatán
las
and Chiapas,
condiciones
who
locales
have
para
been
poder
working in
avanzar
accelerated
más que los
efforts.
otros 5
They
estados que
have
también participan
implemented
desde principios de 2020 en HART.
actions, local actions, to
Y
introduce the
la
HARTS
incorporación
initiative.
del módulo D como tal
And I'm going
surgió como
also
un compromiso
to
adquirido
talk about
en el mes
the
de junio
inclusion of this
de este
module
año,
as of
en el taller
June
que organizó
2023.
la Organización Panamericana de la Salud, un taller subregional,
When we
donde
attended this
se
original
retomó la
workshop
necesidad
from
de
PAHO
seguir avanzando
that
en la implementación del módulo D
covered
de diabetes.
the
Y
module
posterior a ese taller,
implementation,
estos
the
dos
module D
ejemplos que
implementation
les mencionaba de
specifically for
Yucatán y
diabetes.
Chiapas
And
tomaron
apart
la
from these
iniciativa
two
y
examples,
el
Yucatán and
compromiso de
Chiapas,
avanzar de
they took
manera
this
más rápida.
initiative and they also made the
Entonces
commitment
ellos
to make
en el
progress
mes de
in a
agosto,
quick way.
con,
So
con la
as
asesoría
of
técnica de OPS,
August,
tanto de México
when
como de
we
Washington, se
had a
generaron un par de
technical
talleres
meeting with
introductorios
PAHO and
donde se convocó a las
WHO,
autoridades
we created a series of
estatales, a las secretarías de
workshops,
salud, a los equipos
and
de
we
gestión
called
que
up
tienen que
the
ver con el
local
abordaje a la
and state
diabetes
authorities
y
who
derivado de estos
talk
talleres
about our
iniciales en
plan
cada
for
uno de estos
diabetes.
estados,
And resulting
se
from these
generó también
initial workshops
ya
in each
grupos de
one of the
trabajo en cada estado
states,
para ir
we
desarrollando
created
la vía
work
clínica.
groups in each of
En los dos
those
estados,
states
que son los de
to
avanzada,
develop a clinical guide.
localmente se hizo una convocatoria
And
extensa no solo a los equipos de
from both
gestión,
fronts,
se incorporó a los equipos clínicos, es decir, los
we
médicos,
included
enfermeras,
we
nutriólogos,
formed
psicólogos que están en
the
el primer nivel de
clinical
atención,
teams, the
para que también
nurses,
pudieran ellos hacer
physicians,
las
all the
aportaciones
staff team
correspondientes para el
that was
desarrollo de la
going to
vía.
be part of the
Y este
primary
es un paso
health
importante,
care
ya que ellos son los que se
to,
encargan
so
de
that they could
ejecutarla,
help
por
us
así decirlo.
develop the clinical
En el mismo
pathways.
sentido, dentro de la
And in
Secretaría de
that
Salud,
same
como ustedes saben,
sense,
en México somos un
from the
sistema
Ministry of
segmentado,
Health's
fragmentado,
perspective,
y había la
as you
necesidad
know,
también de ir a
in
tocar
Mexico, we
las
are part
puertas
of
de
a
las otras áreas
segmented
administrativas y de gestión
system.
que no tienen
We
que ver con
started
la parte de la
addressing
atención
the
médica, pero
other
que sí
stakeholders that
influyen en todo el
do not
proceso
necessarily are
de
part
la atención a
of
la
the
salud de
health
los estados,
sector,
¿no?
but are
Entonces también se
part
les
of
convocó
the healthcare system. So we
hubo
addressed
también la
them,
necesidad de escalar esta parte hacia los
and
gobiernos
we also
estatales para que
escalated
también
this
desde el
part
apoyo
to the local
de los
government
gobiernos pues se
so
pudiera
that
impulsar
they
el
could
desarrollo
support
de
us
estas vías.
in the development of these clinical
También
pathways.
me faltó mencionar que dentro de los grupos de trabajo en cada uno de los estados se
Also forgot
incluyó
to
a
mention
líderes
that as part of
clínicos
this
de
effort,
especialidades
we
y
included
subespecialidades,
clinical
¿no? Cardiólogos, endocrinólogos,
experts,
medicina interna, para que
both
también se
specialists and
tuviera
subspecialists,
esta
cardiologists,
asesoría desde el
endocrinologists,
punto de vista
so
clínico.
that they could advise
Entonces,
us
durante el
in a
periodo
clinical
agosto-noviembre,
way.
los estados de Yucatán y
So
Chiapas han
in
trabajado con sus
August and
equipos
November,
y han
Yucatán
hecho
and
ya una
Chiapas have
propuesta
worked with their
concreta para sus
teams,
estados,
and they have
que
came
también
up
vale la
with
pena
a
resaltar,
proposal regarding these
consideran pues,
efforts.
la
It
disponibilidad de
is
los
also
medicamentos que
important to
ellos tienen,
highlight
¿no? Sabemos que en los últimos años se ha intentado hacer
availability
una
of
compra
the medicines
consolidada a
that
nivel
they
nacional
have,
para todas las
and
instituciones, pero sigue habiendo ahí algunos
which
huecos
trying
importantes
to make
en
a
la parte de
consolidated
cómo se programa,
approach
cómo
for
se
all the
compra
institutions,
y
but
cómo
we
se
need
distribuyen
to
los medicamentos.
consider
Ya para la
a
parte
local
de hace
aspect
un
of
par de
how to
semanas, también
procure,
con el apoyo de
acquire, and
OPS,
distribute the medicines.
se
Lastly,
desarrolló un
with the
taller
support
nacional
of
con los
PAHO,
32
we
líderes
also
estatales
developed
del
a
programa
national
de enfermedades
workshop with the
cardiometabólicas,
33 leaders of
y
the
en
program for
pues el
metabolic
compromiso que se ha
and
adquirido con
heart
ellos pues es seguir
diseases,
impulsando y
and
avanzando en la
we
implantación tanto de
push
HART
the
como la
commitment
parte del
of
módulo D.
continuing
Entonces
implementing the
esperamos que
HARTS
durante
initiative as
el
part of
próximo
this module.
2024 pues
So we
podamos seguir
hope
avanzando en las
that in
32 entidades de la
2024 we
República.
continue making some progress in the 33 states
Dentro de los
of the
retos que
country
consideramos
as part
importantes
of
para
the
el trabajo
challenges
de
that
los
are
equipos que
important
desarrollen las
for
vías
us
clínicas,
and
pues
our
es
team.
la necesidad de una integración administrativa, ¿no? Como les
We
decía,
need to
hay muchas
integrate
áreas que tienen que ver
the administrative
en la
aspect
parte
because
de
there
cómo
are a
se
lot
compran
of
los insumos, cómo se compran los
stakeholders that
medicamentos,
are
cómo se
involved
programan, cómo se
in
distribuyen,
medicine
y eso genera la necesidad de que toda la
acquisition,
parte de la Secretaría de
procurement,
Salud,
and
tanto
distribution.
nosotros a nivel federal
And
como en
this
los
is
estados,
part
tengan una participación más activa y también que haya una apertura al
And this
cambio,
is
¿no?
not
Que esa es una de
only
las
in
principales
charge of the
necesidades
Ministry
que
of Health,
tenemos.
but
La
other
necesidad del
government
cambio,
entities,
de
and they
salir
need
de
to
la
be
parte
highly
rutinaria,
engaged in
de
these
las ciertas
processes.
prácticas que a lo mejor no están dando los resultados que
We
esperamos,
need to establish
y
the
que eso, por ejemplo, en el
practices
caso de los
that,
medicamentos
and we need to
específicamente, pues tiene que ver
assess
con
those
una
practices
homologación de
because maybe they're
catálogos
not yielding
y
the
que la
best
compra y
results,
disposición sea
and based on
realmente la
this
que se requiere en
information
las
we need
unidades de salud.
to draft the
También la
catalogs
vía
that
clínica,
are going to be
como ya
useful for
lo
each one
mencionaban
of the
nuestras
health
compañeras,
units. As my
nos
colleagues
obliga a
also
que los profesionales de la
mentioned,
salud
this
tengan que asumir otros roles, ¿no?
information makes
Desafortunadamente
us
seguimos teniendo un esquema de atención centrado
determine
en el
that
médico
the healthcare
y
staff
pocas veces
assume
se
other
reparten las
roles,
responsabilidades con los equipos de
but
salud,
this is not
desde los
something that is
promotores,
commonly
enfermería,
used
nutrición,
because the roles are
psicología,
not
que son muy
very
importantes
well
para que el
assigned,
abordaje realmente sea
but
integral.
all
Otra
sponsors,
cosa
health
que
staff
también
in
hemos
the health
identificado en estos
centers need
grupos de
to
trabajo es que
have
se
very
tiene
clear
que
what
trabajar
are
en la
going to
parte
be
del
the
cambio de
roles.
pensamiento.
From the Ministry
Si
of
nosotros
Health,
seguimos
we need to
haciendo
change
o queremos
ourselves
seguir
as
haciendo lo que
well,
estamos acostumbrados, pues
because
puede
if
ser
we
una barrera
want
que
to
impida
continue
la
doing what
aplicación de
we
este
are
tipo de iniciativas como la
we
la
have
vía
been
clínica.
doing, that could
Y
be
también
detrimental
tenemos
for this
que
type of
fortalecer nuestros sistemas de información
initiatives.
para que
Also,
realmente
we
sean
need to
un apoyo a la
strengthen
toma de
our
decisiones para el
information
equipo
system
clínico
so
y
that we
también para la parte
can
de los equipos de
support in
gestión
terms of
y de
decision
administración de
making
salud.
for all the stakeholders.
Estos son los dos
These are
Do you hear me? Yeah. Yeah, as I said, as countries are making and And some technological hiccups. Since we have some time constraint, we will maybe focus not much on the problems, but more of the country experiences and solution in trying to improve diabetes medicine and technologies. And I think perhaps one important dimension when we discuss diabetes in comparison to other conditions is that medicine and technologies now need to come together. That bundling of medicine and essential technologies for the monitoring, I think, is critical. And as countries are moving on universal coverage, I think that aspect is important. I have the chance to have, again, on this panel, 4 countries plus one perspective from the region. The colleague from the PAHO Strategic Fund, Dr. Nora Garan-Aguilar, the regional advisor from the PAHO Strategic Fund, will not be available with us, but we have a short video. But I will start from my left, from right to left, by Dr. Miguel Angel Diaz-Aguilera, Director of Adult and Elderly Health Program. Again, another colleague from Senaprese, from the Secretariat of Health of Mexico. Welcome. Madam Gilmara dos Santos, General Coordinator for the Prevention of Chronic Condition in Primary Health Care from the Ministry of Health of Brazil. And bear with me if I mispronounce your name, please correct me. Dr. Ximena Niquel-Huenque, Diabetes Focal Point from the Department of Non-Communicable Disease of the Ministry of Health of Chile. And Dr. Beatriz Stusser, Head Endocrinology Service at the Galisto Garcia Hospital in Havana, Ministry of Health of Cuba. So to start, perhaps if we can put the videos from the PAHO Strategic Fund, which is a major innovative, I think, approach in the region. It's quite unique in trying to support member states in the region in pool procurement. So a very important initiative for NCD and for broader than NCD, but I think in NCD, both for cancer, but also cardiovascular and diabetes medicine across the NCD list that the colleagues have highlighted. PAHO is Strategic Fund is making a major contribution. So please, if we can launch the video.
Good morning, everybody. I'm the advisor of the OPS Strategic Fund. Thank you very much for allowing us to participate virtually in this panel, which is addressed toward encouraging the access and availability of drugs for the diabetes care. I'm going to start by presenting what are the regional funds and how are they structured in the PHO in order to provide an effective response to the member countries. This fund this year were joined in a special program where we have the presence of the rotatory vaccination fund and the strategic fund of the PHO. This is the technical matters that allow the Americas countries to have access to essential medications and the vaccines through a process of consolidation of the demand. We made the regional procurement for the state members, obtaining better prices and promoting planning of demand in a joint way in order to obtain a benefit for everybody. The support provide huge benefits to the region. First of all, they warranty the quality level, complying with all the international OPS and the PHO and WHO level, but it also accompany the state members to meet the regulates established in the PHO and the WHO. One of those purposes of the funds is to support the countries to encourage the national capabilities, specifically in the area of improvement in their provision supply management in order to have an on-time supply. We work together with other allies in order to improve the price negotiation and to reduce cost of the products, making the procurement more efficient and improvement the use of the financial resources of the state countries. This is a value added because it facilitates the financial lines, for example, credit lines, because they can have a credit at no interest rate to improve their procurement processes whenever they want. The strategic fund in the last 5 years have been working together with the member countries in order to improve it for the essentials, making an agreement for 55 participating entities, 35 of which belong to the Ministries of Health in the ministries and territories, and 20 belonging to state entities representing the social security and other public health institutions of reference in the region. In this line, more than the 130 millions were benefited, and we have procured in the name of the country members more than 900 millions on drugs. This is strategic fund. It's very wide, working together with the country members, and integrally we have defined a portfolio including medicines for transmittable diseases, for non-transmittable diseases, and for unattended diseases, as well as all those inputs for the diagnosis and medical equipment required by the countries, as well as vectorial inputs. At a certain point, we also work with a portfolio for COVID in most of the countries. In the case of non-communicable diseases, we have a very wide portfolio to support medicines, technology for hypertension and other chronic diseases that countries have been requesting for in order to take care of many other diseases. In this line, this year, after launching the initiative for the care of non-communicable diseases, with the main aim of the first level of attention, we have established a group of technologies and medicines as the essential pillar for this initiative. This portfolio was performed and developed based on recommendations of the WHO and the WHO, following the guidelines and principles established for the treatment of NCDs, but also checking and analyzing the requirements from each country in order to respond to their needs, and developing any integral activities, including medications and equipment, so that countries may use and buy medicines or equipment separately, considering that this is an integral response to take care of these diseases. We have included a list of medicines as essentials for the WHO, as well as medical equipment and inputs. Within the medicines already included are insulins, both intermediate and short action, but we also have metformin in different presentations, and glycoside in different presentations too, which are the ones that are mostly used in the region. We also have developed a list of medicines, and we know that most of the countries are using still dagliafanida. Therefore, we have maintained it in the listing. This year, the technical units recommended that other products that fluoromacin and glycoside, which are high-cost new products for different countries, but that are necessary to take care of other diseases associated, like heart insufficiency, failure. We also have the glucose measurement devices in blood, electrocardiograph, which are products that were assessed and validated clinically, as well as recommended in the Hearts Initiative for the countries that we have been supporting for their acquisition. This is a projection for the 2024, making the consolidation of the product's demand. We have been working with some countries to act as intermediates for the both of metformin and glycoside. As you have seen, we have been doing these activities for the purchase of these products in the 2020 prices. We're not quite competitive, but in the 2024, when 3 countries requested this product, metformin, 500 mg, we obtained a very competitive price, and we expect that for the 2024, if more countries consolidate the demand for the procurement, we may get more competitive prices in order to make more efficient the procurement process. And in the case of glycoside, we have analyzed the backgrounds in the 2022, and we noticed that in that year, 1 tablet was 0.28 USD, and the 2023, through the negotiations of the WHO, they decreased 25% to 0.07 US dollar per tablet, which makes the treatment more affordable for the patients receiving this therapy. We have been working in the 2023-2024, asking the countries to participate in the regional consolidation of drugs for diabetes and other NCDCs. This is a key process in order to make the planning for the procurement for the countries, allowing the strategic fund to develop negotiation joint plans more organized, trying to find other suppliers to improve the price and achieving better prices. 7 countries joined this regional consolidation in the 2023, considering that the volumes are quite appealing to have an international bidding process in order to integrate the prices according to the prices obtained for prior years. Hopefully for next year, we may have reference prices with assessed suppliers in order to have these products. Besides having access to high cost and medical devices, this is a work that we made with the 7 countries that you can see in the map, but that hopefully all the countries in the region can be benefited. Finally, this is the technical cooperation provided by the strategic fund in order to continue supporting access of medicines based on the analysis, the featuring of the supply, and all the elements associated to this management, such as the quantification and appropriate planning of resources, training of health people with this planning process and drug procurement, everything about the suppliers management, as well as the criteria and standards set forth within the pre-qualification of the WHO, and the support in the monitoring process, receiving sending, shipping, as well as the review after the delivery on the products and monitoring of the stock in each country to prevent shortage, resulting in an on-time access to these products. We are fully available to support all the countries as may correspond in order to provide a better answer to their needs and complying with the goal of having better access to all the medicines. This is the information with the available medicines in our organization, as well as the contact to answer any question that you may deem required in this process about medicines supply.
Many thanks indeed to our colleague from the PAHO Strategic Fund. I think it's a very important example of an integrated end-to-end mechanism to improve the efficiency of procurement. I think there were some very important elements presented here that apply to all countries, making sure that whatever you procure are quality assured. I think the first element is to make sure that whatever is delivered is safe and effective. The second is perhaps uninterrupted supply, being able to predict the needs at the country level and being able to maintain stock. And in chronic disease management, we know how much difficult and challenging it is when countries cannot maintain their stocks and people have to change regimen. The transparency of price is an important element, and being able to have a process. And many countries are going on bilateral mode to try to get the best out of it. But of course, with the confidentiality contracts, you are sometimes caught in very difficult discussion with the suppliers, and being able to have exchanges across the region and the countries about the price and the best price that you can get from tenders, I think are critical. Because by driving the price down, as we have seen, you can make better use of your resources and maybe develop and redirect your resources to other aspects of diabetes care. And I think I really recommend this effort in the region also to, we are learning by doing it. You have seen only 7 countries for the moment, but if we can consolidate more the demand, I think it should be something that we all could learn from across the region. We will now turn to the country expenses. As I mentioned, we have about less than half an hour, so perhaps cautious of the time. We will not look on the problem, is more on the solution, and perhaps I will ask our panelists to really share just briefly some of their country expenses in improving access to medicine and technologies. And we'll start with you, perhaps Miguel, from Mexico perspective. You can speak here or maybe at the desk as you want.
Maybe just here. Okay, in Spanish. Ok, entonces, como somos más los que hablamos en español.
Okay, as we are more people Spanish speaking, we are going to speak in Spanish. To that extent, Mexico, from the beginning of this administration, one of the central focus has been to have this change in the health service and also this access to technology and to medicines that may change the outcome of these health circumstances. Certainly, early 2020, we started a whole change in the approach of the cardiometabolic diseases, starting with hearts as a starting point, in order to get more patients with these conditions, starting by hypertension without putting aside the rest of the conditions. Because one of the essential items is that these health conditions are hardly by themselves. Usually they have a metabolic syndrome, or they come in 2 or 3 diseases together. So we started with hypertension without putting aside diabetes, and the rest of the risk factors. And one of the main points of this transition was the acquisition of new technologies for the accurate measurement of blood pressure. Together, monitoring, that was already mentioned, which is very important. Having in the clinical spaces access to glucosylate hemoglobin as a starting point in order to make a better decision regarding the change or the transition of treatments for the patients that we were taking care of. Now, there have been a lot of challenges. One of the biggest challenges was that 2 weeks after the launch at world level of the Hearts Initiative in Mexico, we had this blockout because of the pandemic. We continued working, but almost 90% of the medical service reported a relocation of the medical staff taking care of these conditions. Most of them kept at home because they were in high risk, and the other 20% are just taking care of the pandemic. In addition to that, we have a lot of patients that they thought that they were going to be getting the disease, not in the hospital, but because they had to use these public transportation services. Despite that, the federal entities in our country made a good effort to maintain the approach in order to continue this monitoring of the patients, but mostly not to leave them without medications to maintain the control. After the pandemic, we started with this recovery of patients, which we are still recovering because literally we haven't been able to go back to have the same number of patients as before the pandemic, because the inertia since from the patient point of view is that they are not going back. However, those patients that were already recovered, they are being supported. We are providing a more consistent care. Control has been recovered in some of them, and we are also trying to have this treatment transition. Another of the advantages of these new public health services is the paradigm about the treatment, not only for hypertension, diabetes, and lipidemia, to focus on the risk factors in order to make a better decision regarding the coverage of these patients, in order to be able to start with the drugs as early as possible to escalate the treatment in less time. Obviously, we're required by the patient in such a way that we may prevent to enlarge the time of the therapeutic treatment with these patients. And on the other side, trying to decrease this inheritance. I think these are the main points.
Thank you very much, Dr. Miguel, indeed, for highlighting perhaps a few elements. Heart's approach as a way really to standardize care, and including, the A of Hearts is an access to medicine and being able to bring this in an integrated manner with a focus on hypertension, diabetes as entry point, but also making sure that the essential requirement in terms of medicine and technologies are part of this. And as also you highlighted the importance and unfortunately the impact of COVID on healthcare, and specifically for people with chronic condition, and how the recovery will take time. But I think being able to have Hearts is a timely manner also to support you in that recovery phase. And we'll get back to you perhaps if we have time on the specific discussion about prioritization of medicine for diabetes. We'll now move to Brazil. Same question, perhaps you are.
Bom dia, buenos dias. É com muita satisfação irei falar em português.
We have a good control of diabetes, and we have important information so that we can understand the importance. And then we have to talk with the perspective and to talk on the medications and technologies in a country, because we have about 6 million people registered in the first level care for diabetics, 16 million of people. That allow us to see the importance of investments, resources, actions in order to ensure this access. This is a matter that I am considering, and it is very important because our approach today is diabetes, but we have to understand this dynamic, and we must think about the strategies and medications for this status. Regarding obesity and physical activity, we find that it is very similar to the approach mentioned by Carmen and Silvana, because in our case it has been increasing. The number of inactive obese people, I can give you an example. About 6 million people with obesity in Brazil, which is also a very representative figure. The impact of this situation financially for resources and for hospitalizations, we can understand that in 2020 the cost was more than 60 million pesos of our currency in treatments. And to reach the technology, the scenario that we can foresee is that only 22% of our patients had access to the hemoglobin test. This is another program that we can mention. With the medicines, we can understand that it will allow us to have essential medicines. We have been doing some progress, but we are trying to discover. I think that a part is coming from the federal or state government.
The government, especially the administration of President Lula, and with the increase in the cost of different components, actually insulin and different type of insulin are managed by the Ministry of Health. We co-fund the medicines, but basically we have the task to support the Ministries of Health, but that doesn't mean that we don't have anything to do with the medicine, and that's the problem. We need to increase the equipment of primary health care. Around 52 million types of equipment are included in our portfolio, and I invite you to refer to that. And we're actually in the process of reviewing that portfolio because we have different elements that we are going to start monitoring, both the acquisition and the distribution and the access of the users to these medicines. We want to tell them that we are working on the advance and the procurement of these type of projects. And we know that we think that we are going to advance in the collaboration with several experts, and a certain type of products have to do with the diagnosis. We're working with nutrologists, physical therapy experts, psychologists, etc. But our electronic portfolios strongly has to do with different components that need to be covered so that we can offer support to the staff of primary health care. But there are some that we don't have available in Brazil, for example, endocrinologists. And in terms of hypertension, there are millions of people that suffer from this condition. And maybe the situation is similar to the one in Mexico, but also we face some challenges. We have a population that is impoverished, they lack access to food, and most of the population don't have access to food. So that we need to include a perspective of the light technology, we need to establish dialogues, and we need to foster investment in Brazil with self-care, and we need to include all of this in this process, because we are not only focused on the provision of medicines, but also the treatment, the complete treatment. So, in summary, we can present these, and based on this presentation, our efforts is making a lot of progress, and we thank the PAHO for all the support. We need a close relationship, we need to foster more discussions, and based on the state agreements and the municipality agreements, we need to come up with the solutions presented in the actions. Everything, all technology that is included in these efforts needs to be based on a national coalition that has to do with both the states and the municipality efforts. And also in Brazil, this is an important aspect to have success. And for I don't know how we're working with the federal government. This year we were still working with resources from the last administration, so we need to continue establishing dialogues, and Lula's administration are going to invest in these programs, especially for cardiovascular diseases and the risk. And for those who don't know, well, the policy for the improvement of the healthcare system and also the administration of President Lula are going to be involved here to expand the efforts to prevent, control, and manage the NCDs. So I would like to thank you for your invitation, and I'm open if you want to ask me and if you want to know more about our experiences. So thank you.
Thank you very much,
Muchas gracias, doctora Santos, por compartirnos la experiencia de Brasil. Y ahora vamos a seguir con Chile. No se estaba escuchando. So the question, I didn't hear the question. Can you repeat that, please? Bueno, la pregunta era que quería pedirle que nos contara de las experiencias de su país. So thank you for your invitation. I feel very honored of participating in this session, and I'm going to tell you what's the stand of Chile in prevention and care of this type of diseases. We as Chile, we have a lot of history in primary healthcare, which is strengthened. Around 80% of the population has access of the public healthcare, Therefore, most of the population that suffers from diabetes is concentrated in this 80%. This is located in all the country, but this healthcare system includes general physicians and family physicians. And as part of this primary healthcare system, we have the lay on explicit healthcare, which was issued in 2005 based on the health reform experienced in the country. And this law covers the monitoring, treatment, and diagnosis of people suffering from chronic diseases like hypertension, diabetes, and cerebrovascular accidents. Diabetes especially are covered in handling and diagnosis and the treatment of oral hypoglycemics agents and insulin and all the medicines necessary for the treatment of this specific type of people. We also have a program for strengthening the handling of treatment for people suffering from chronic diseases. This is called SOFA, and this includes technical aid to handle the treatment for people suffering from chronic diseases. And the law risotto from Chile also covers treatments, high-cost treatments, where we provide funding for this type of treatments. And we included type 1 diabetes with certain conditions and inclusion factors to provide provision of insulin and other types of medicines. Also, in terms of technologies, we are currently using digital medicine. We have an activity called Digital Hospital where we treat people suffering from diabetes. It also provides support for general physicians and the healthcare that they provide. Also people that need advice in changing the type of therapy that they are taking. And also we are working with different specialists, but as the rest of the countries in the region, this is limited. So people included in the primary healthcare system can access to these tools. Apart from diabetes-related complications, we also have a diabetic handling. We provide treatment for feed conditions related to diabetes, such as people suffering from diabetic ulcers. And this has allowed us to improve the efficiency in the treatment that we provide and guarantee healthcare. We also guarantee for all the people that require this treatment for kidney disease, diabetic kidney disease, and this is provided and guaranteed to all people regardless of their origins. But 40% of the people receiving this type of treatment are the ones suffering from diabetes, and this is some of the advances that we have made in these years. Also, I wanted to mention that we have a cardiovascular health program that started around 2002, derived from the reform, and this program started by providing treatment for people with risk of stroke. So basically the goal of this program was to reduce the risk of people suffering strokes, and in this program we started attracting more resources that would allow us to prevent this type of incidents. And basically those are the advances from Chile. Thank you.
Muchas gracias y vamos a terminar esta ronda de perspectivas con la última presentación y después vamos a pasar a la sesión de clausura.
Well, good morning, everyone, and thank you so much for inviting us. Cuba, and as you know, in our country, the healthcare public system covers all people. That means we don't have a private healthcare system. Therefore, the primary healthcare is deployed to everyone, to all the population. We have 450 consultants for family medicine and other part of the system that are made up of pediatricians, other specialists. We also have the polyclinical aspect of the healthcare system, which includes different specialties that basically provide care for all the people. In the municipalities where we don't have this type of specialist, then we have the secondary healthcare like endocrinologist and other specialists that would provide this type of healthcare to the population. Since the COVID crisis, everyone had different products provided, like glucometers and other medicines. But since that, we continued working in strengthening this system. Last year, we started working in strengthening the hypertension aspect of the healthcare system. And we also started working in the clinical aspect for the provision of treatment of diabetes. And just like the other countries, the endocrinologist associations, the nephrology, the internal medicine associations, all the health staff met and started working together to come up with a consensus to unify the criteria. We also received the visit of Dr. Carmen when we approached certain corrections in the clinical guide, and we hope that in 2024 we start implementing this guide. The main challenges for us is technology, because in this time we don't have the glucoside medicines, and for glucometers we don't have enough to provide to the rest of the population, and this is one of the main challenges. So one of the main challenges is to define if we're going to provide the glucometers, because with each package we used to provide them with a package with reactive strips with glucometers, and we haven't defined if we're the ones that are going to provide that or not. So that's the main challenge. We do have, however, some of the medicines to treat diabetes, insulins, NPH, and fast-acting insulin as well. And that's how we are treating diabetes, and on that information we are basing our clinical guide for diabetes. But this is a challenge that we are facing, but we want to provide an inclusive healthcare system, because we have nephrologists in the clinics, and this is going to be very useful from the clinical perspective, especially when we're dealing with kidney diseases or other cardiovascular related diseases. So thank you.
Muchas gracias a todos por venir y por compartirnos sus experiencias y sus perspectivas. Creo que todos estamos juntos en el mismo bote y hay muchas similitudes en todos los países. Compartimos varios retos. independientemente de si sean países pequeños o grandes, enfrentamos retos muy similares en términos de medicina familiar, de medicina especializada. Y bueno, nosotros estamos tomando acciones, pero tienen que estar informados por evidencias. Por ejemplo, en el ejemplo de Chile, nos compartieron que lo que la gente se puede beneficiarse, de lo que la gente tiene que hacer para continuar con esta atención médica y para que esta información sirva para invertir y hacer avances en términos de enfermedades cardiovasculares. Y bueno, y ya sabemos que tienen mucha información que han incluido en los documentos, especialmente la guía clínica. Y bueno, esto nos va a servir especialmente a nivel internacional para abordar estos problemas, en especial para la obesidad y la diabetes. Y bueno, ahora tenemos un enfoque más comprensivo o integral, perdón, para abordar no solo la hipertensión y la diabetes, sino enfermedades cardiovasculares, y esto nos va a utilizar mucho en la comunidad internacional. Así que muchas gracias de nuevo por sus experiencias. Muchas gracias a todos por haber venido.
Agradecemos la participación de esta mesa.
We thank the participation of our panelists, Dr. Miguel Ángel Díaz Gavilet, Dr. David Mano Santos, Dr. Jimena Nabulquerque, and Dr. Beatriz Strasser, and to our excellent moderator, Dr. Slim. So, before the closing remarks, we invite Dr. Moreira, representative of the Pajo Regional Office in Mexico, for the closing remarks. Good morning, everyone. Thank you so much, dear Dr. Lopez, Undersecretary of Health. It's great to see you. Cheers to our colleague from PAHO and WHO, Dr. Slim Sama. It's great to be here in this WHO and PAHO event. Thank you to the rest of the team. Welcome to Mexico. We know that you're part of the mission. Our colleagues from WHO and PAHO. Since last week, you've been traveling through the country in Chiapas, Mérida. So we're very glad to see all your efforts in Mexico. So once again, on behalf of Bajo Mexico, welcome. I've been paying attention to the last presentation, and I'm very glad to hear about all the country's advances, and obviously being part of those efforts, and also listening to the different accents and the different colleagues from all countries, from Dominican Republic, from Brazil, from Cuba. So it's great to see you all. So, hi Marta, hi everyone. It's great to see you, and it's great that we have a very useful session in the World Day for Diabetes. Here in Mexico, we shared numbers, information, and hard data, and the advances that all the countries in the regions are doing to address the issue of diabetes in the region, because unfortunately, and this is true, these statistics regarding diabetes are going to increase in the next years. But it's great to listen to all the changes and all the actions that the countries have implemented to address this issue. And all of us from the Ministry of Health in Mexico and the regional office, we're highly committed in the prevention and care for this disease. This is the clear goal, right? Once we detect this disease,
disease. When we make the diagnosis, we need to make a follow-up. We need to see which medicines are available, is the technology available to tackle and to treat the person suffering from diabetes, because we've seen that sometimes there are some complications that can arise, like issues with the kidney and with the heart. So it's great to see all the great advances regarding the prevention of this disease. It's great to see all the estimations regarding the acquisition of medicines, especially here in Mexico. When you see to the supermarket, you see all the octagons. You've seen, I have gone to the supermarket and see to the pharmacy and see the octagons, and it's great to see that there's been an increase, and we've implemented different actions like taxing different products like alcohol, tobacco, etc. And fizzy drinks, for example, and this is great in our battle against this type of diseases. Also, we've faced some challenges in providing a comprehensive treatment to the people suffering from these diseases, but I know that we're doing some things, and we need to acknowledge that, especially because this is a pandemic. And just some words regarding the presentation from Nora Giron, who talked about the strategic fund. I think it's important that all the countries review this topic, because especially if you try to acquire with the rotative fund, there's going to be a trend of the decreasing in cost, and this is going to ultimately benefit all of us. I'm also glad to learn Arriola's without. As I mentioned, it's been great to listen all the countries. So once again, thank you for sharing your experience, and I hope we had a great session. Thank you. So thank you for the closing remarks from host Dr. Arriola. And Dr. Slim Slama, please take stage for your closing remarks.
Thank you very much.
Muchas gracias, seré breve, ya escuchamos muchas cosas, pero desde la perspectiva de la OMS, esto ha sido muy inspirador. Entonces, de nuevo, muchas gracias por la oficina regional, a todos los participantes aquí, y especialmente a los colegas de la Secretaría de México y de la oficina regional. A veces estas reuniones parecen triviales, pero sabemos que hay mucho trabajo detrás, así que muchas gracias por ser los anfitriones de este tipo de sesiones. Bueno, solamente algunas palabras de clausura. Lo que vimos en esta semana, para enfocarnos a la crisis de cáncer, vimos que estamos en una situación de crisis constante, algo que el Fondo Económico Mundial se refería como una crisis multisectorial, porque estamos enfrentándonos en una situación donde desafortunadamente hay un impacto económico resultante de COVID, de desastres naturales, del cambio climático, y estos impactos los vemos en esta región. Recientemente todas las situaciones que vemos en el Medio Oeste, y con base en esto tenemos que crear sociedades resilientes. Esto es esencial, y esto solo se va a lograr al continuar construyendo e invirtiendo en la cobertura de este tipo de servicios, especialmente para la atención primaria. Hemos visto que en la pandemia de COVID-19 la mejor manera de salvar vidas es invertir en el sistema, fortalecer las sociedades y las comunidades para que nos den apoyos, para anticiparnos y poder prevenir un impacto mayor. Entonces, la mejor herramienta es invertir y asegurarnos de seguir haciendo avances en esto, en especial para diabetes, de tener sistemas de respuesta listos con base en el contexto de cada región, porque con base en esto vamos a poder organizar estrategias en el mundo. Y un colega de comunicación nos estaba preguntando cuál era el mensaje principal. El mensaje principal es que vamos a avanzar con la región para garantizar la atención primaria, pero tenemos que colaborar en la contextualización, es decir, en el contexto de cada país. Tenemos que trabajar con las comunidades, con los diferentes sistemas para ver qué vamos a hacer. Tenemos que tomar en cuenta muchos factores diferentes. Eso ya lo mencionó nuestro colega de la Secretaría de Salud. Tenemos que incluir las políticas de transición, todos los aspectos para tener un impacto global, pero tenemos que tener presente que la contextualización es esencial para atacar las necesidades específicas de sus comunidades. Tenemos que tener en cuenta el contexto, pero tenemos que ser lo suficientemente flexibles para construir algo que sea lo suficientemente estable y fuerte para atacar estas crisis. Lo último que me gustaría mencionar es que estamos aquí para servir a la gente, para servirlos a ustedes, y estoy muy contento de estar con ustedes, de ver su valentía, de ver cómo es que trabajamos. Sé que están en una posición en donde estamos participando altamente. Sé que hay muchos retos, sé que es muy complejo, sé que tenemos que hacer mucho trabajo, pero estamos con ustedes y quiero asegurarles que en todo lo que hagan para mejorar sus sistemas, que las comunidades los apoyen en esos esfuerzos para que podamos crear algo que sea relevante para ellos. Y con esto termino mis palabras. Muchas gracias.
We thank the final remarks of Dr. Slim Slama. Please, Dr. Rich Rama, come to the stage.
Muchísimas gracias. Gracias, Dr. Moya. Thank you very much. Thank you, Dr. Moya. This morning, I was telling you that you were inaugurating this emergency equipment event that I was also invited to, but I decided to attend here. But yes, I do understand. Thank you very much for coming here to the most important part, that is the closing. You also had the opportunity to see these two discussion tables, which are the essential part of the program. I do not understand, because I think, I don't know why the WHO, the PHO have all these multiple sessions at the same time. I think you have to check your planning, because right now I have half of my staff in Brazil, India, and many other places attending meetings that you kindly invited us to. But thank you very much. And I also thank you very much for sharing your experience. It is very important. And the part of the message at the closing is that Latin America had a period of structural reforms that, regardless the ideological part, I think that maybe we can agree that they were not successful. I think that we have to accept that, we have to measure that. I think that in general, the structural changes or reforms in last 30 or 40 years, and I know perfectly Chile, Brazil, Colombia, all the countries had their amendments, but I think this getting away from the health system attention or care, getting far away. In Brazil, for example, a part was lost, but in Chile they have and strengthened, because they have these legal changes that ensure. But now we have to see how much that has been translated, especially with the counter reform. And I think that you are right now actively discussing that to rescue the primary health care, because I think that it was affected too. Also in Argentina, I think that we must understand in this transition of reforms and counter reforms, we have to consider the care of these diabetic people as something to be rescued. It is quite important to see that here is where we are going to be measured. We, in our reform that we are doing, but also too, and all the other countries in the region to see how they were impacted. All these experiences were really very useful to understand. And now I would like to ask the PAJO to continue encouraging these discussion panels, especially at these times where we are having so many structural changes in the region. The other element, I think it's quite interesting, and I think the presentation next week, we are going to be visiting the OPS drug administrator. We have also an experience on that regard, and here I would like to thank the international team, Dr. Marta Caballero, Daphne, because since we started here, they promoted this access to the funds, but despite all these years, we haven't taken advantage of them. In general, we haven't done that because of different stakeholders. I am sorry, I'm going to say it. They are not that good. We may get some other better things. When I see this decrease in the prices, and when we see the feasibility of the prices that we can get in Mexico for the instruments and the medicines and the diagnosis devices, it is not a fact that we have better prices, but it is interesting that the big countries in the region are not using them. Brazil is not using them as far as I saw. Brazil did. Chile didn't. So we have to see which are the barriers that each one of us are finding, because sometimes these are common barriers. It's not only what they offer, but also to know why they are not being appealed. I think this is an interest conflict when we purchase the medicines, and I think that we have to overcome this challenge. Thank you very much. Next week we're going to be really interested in this meeting. Thanks for organizing it. And last, thanks for organizing it. I think that what you showed us about the diabetes compact, sometimes we think, well, when I feel something in the people in the different regions that they are talking with entire transparency, sometimes the international organizations have a hard time to talk with transparencies because the state members are the paying ones. So it's like a relationship saying, okay, whatever you say. And I understand that in the PHO, it is not easy to be proactive. It's like making them to do so. They work for the funds, and sometimes this kindness is excessive. I am glad to know. And I think that we have to consider this diabetic compact as the good practices, as recommendations. There are central things that I haven't seen before, because I thought that it was just a set of recommendations and suggestions. But now I can see some proactivity, at least in the people who talk about this. And I think it's going to be like that. So I would like to participate proactively in this regional diabetes compact with all the elements regarding prevention and also the access to medicines and devices and all that. So thank you very much. For me, this was an excellent seminar and an excellent way to commemorate the World Diabetic Days in this 2024. I hope that for the WHO and the WHO have covered the outcome and the expectations. So thank you very much to all the organizers, translators, supporting people in the hotel. Thank you very much. And I'm sure that we are going to be seeing each other very frequently. Thank you very much. Okay, now we are finishing this regional commemoration of the World Diabetic Days. Thank you very much for attending, and we are asking you to join this commemoration of the World Diabetic Day.